Okay. And let me see if I can get something running. Here we go. Hello again. It's Dmitry. There we go. Okay, so today I'll be reading from the first aid textbook once again on the high yield systems. And so for this particular section, you're going to want to have your first aid textbook. I'm using the most recent edition. The one that I have as a PDF is actually a more earlier edition, but I'll follow along from there. This is going to be the high yield section, so basically this is not necessarily going to be like a very clear, concise, systematic run through of a particular system like the kidneys or the liver or something like that. This is going to be a kind of a general rundown of all the content you would want to know for the first for the step 1 exam. So we'll start off with a quote here, or a couple quotes. We'll just go through them. Study without thought is vain. Thought without study is dangerous. Confucius. So true. It is better, of course, to know useless things than to know nothing. Lucius Annaeus Seneca. I'm not sure if that's... I don't know if I agree with that necessarily. For every complex problem, there is an answer that is clear, simple, and wrong. H.L. Mencken. Wow. That's really deep. Wow. Okay. No, but seriously, okay. The following tables represent a collection of high-yield information about diseases and their pathophysiological mechanisms, clinical findings, and key associations. We have added a high-yield pathophysiology of important diseases section for review of disease mechanisms and removed the classic relevant treatments section to accommodate the change in focus of the USMLE from pharmacology to pathophysiology. Now, I'm not sure if that says it all in this PDF that I have available, but that's what I have in my most recent edition. So it's been kind of a transition, they say, a little bit from it says accommodate change in focus from pharmacology to pathophysiology. So, they used to say a lot, the two big things for step 1 and for COMLEX is bugs and drugs. So you want to know all the different kinds of bugs, microbes, think about viruses, bacteria, different kinds of things that could lead to a pathology, particularly of a microbiological origin. But you also want to be able to be familiar with your drugs, basically know everything about everything in terms of the pharmacology. Antidepressants, statins, antifungals, antibiotics, cancer treatments, whatever it might be, that kind of thing. So those are very comprehensive topics. And also, of course, if you know a lot about those two different things, you should have also a pretty good understanding theoretically of the pathologies that they would treat, or in the case of the bugs, what kind of pathologies they cause, and then also from that you would also have an understanding of what the normal physiological processes would normally be, right? So let's get into it. So you have a classic. Here's this. The PDF says classic presentations. My thing says pathophysiology of important diseases. So honestly, you can read this if you want to, but I'm going to go read my section, and I might just try to skip through just to make sure when it aligns or not. My thing starts as Lesch-Nyhan syndrome, or Lesch-Nyhan, I guess might be a more correct way of phrasing it. I think there's a disparity in terms of how this is structured from before. So this one is a little bit different from what I'm working with right now. And in all frankness to you, I'd rather work with what I have afoot rather than working with this one. So I'm just going to go and check the pages just to see if they actually start with pathophysiology of important diseases at all. They might not, in which case I should just abandon all hope on this matter. But we'll see what happens. Interesting. By the way, this is like 30 pages, so this is probably going to take me a few hours to get through. Yeah, no. This is a completely different setup, I think. So I'm going to read my section. You can read the PDF if you want to. It's going to be a disparity between the two. I need something obviously on the screen at least, but ideally they're going to be relatively similar to one another. In this case, it might be pretty disparate in terms of how they're organized. So let me go back up. Okay, here we go. So I'm just going to read from my book. You do what you want. If you want to read from the most recent textbook, go right ahead. If you want to read this one, you can do that too. And if you want to go follow along with my voice, you can do that as well. Pathophysiology of important diseases. Lesch-Nyhan syndrome. Mechanism: defective HGPRT, leading to an increase in de novo purine synthesis, leading to an increase in uric acid production. Page 35. Along with that, by the way, basically what happens is that HGPRT is defective. That means you cannot recycle these purines, essentially. There's a breakdown in DNA and RNA to make GMP and AMP and inosine, and you eventually make hypoxanthine and xanthine. You can't actually have, if you have a defective HGPRT, you cannot recycle. And so as a consequence, you actually have to generate more than you normally would in order to compensate. And you also can't get rid of it as easily because now you have no ability to get rid of it by recycling. And so as a consequence of that, you have a buildup of xanthine and hypoxanthine. And if that's the case, you're going to have a higher levels of uric acid, and therefore you're going to have higher risk for gout. So that's really the problem with Lesch-Nyhan syndrome, is the gout problem. Also, you will bite your fingers and stuff like that in Lesch-Nyhan syndrome. So just keep that in mind as well as in terms of clinical presentation. Lesch-Nyhan syndrome. Lynch syndrome. Next one. Lynch syndrome, HNPCC. Mutation of the MMR genes, MLH1, MSH2, leading to failure of mismatch repair during the S phase. Microsatellite instability leading to CRC, 80%. Beta thalassemia. Mutation at the splice site or promoter sequence of chromosome 11 leading to a decrease or absent beta globin synthesis. Okay. Osteogenesis imperfecta. Mutation in COL1A1 and COL1A2 genes, leading to a type 1 collagen defect, leading to an inability to form triple helices. Osteogenesis imperfecta can be pretty nasty. Ehlers-Danlos syndrome. Faulty collagen synthesis, leading to hyperextensible skin, hypermobile joints, and easy bruising. Manx disease, or MENKES, Manx disease. Defective ATP7A protein, impaired copper absorption and transport, leading to a decrease in lysooxidase activity, leading to a decrease in collagen cross-linking. Marfan syndrome. FBN1 mutation on chromosome 15 leads to a defective fibrillin 1 glycoprotein, normally forms sheath around elastin. Prader-Willi syndrome. Imprinting or maternal uniparental disomy, 25% of cases, leading to a deletion or mutated expression of the paternal allele on chromosome 15. Again, I'm actually not really a big fan of how this is described because it doesn't really go into what are the actual consequences of it. Prader-Willi syndrome, the person tends to have some degree of intellectual impairment, some behavioral abnormalities, and they're going to be kind of overweight. Typically, they're going to be very hungry. And so, again, unfortunately doesn't describe that very well. It describes the mechanism in a very basic sense, but doesn't describe what are the actual meaningful consequences in terms of clinical presentation, which is what they actually do care about in the exam a lot of the time. Perhaps they assume the person who's reading it this far already knows the clinical presentation. I guess in some cases I do. In some cases I don't necessarily. So they're only really describing the mechanism. Angelman syndrome, imprinting or paternal uniparental disomy, 5%, deletion or mutated expression of UBE3A on maternal chromosome 15. Cystic fibrosis, delta F508 deletion in CFTR gene on chromosome 7, leading to an impaired ATP-gated chloride channel, causing impaired secretion of chloride in the lungs / GI tract and reabsorption of chlorine in sweat glands. Duchenne's muscular dystrophy, dystrophin gene frame shift or nonsense mutations leading to a loss of anchoring protein to the ECM dystrophin myonecrosis is caused by Duchenne's. Becker muscular dystrophy, non-frame shift deletion of dystrophin gene, less severe than Duchenne's. Myotonic dystrophy, CTG trinucleotide repeat expansion in DMPK gene leading to an abnormal expression of myotonin protein kinase leading to myotonia. Fragile X syndrome. CGG trinucleotide repeat in FMR1 gene leading to hypermethylation of cytosine residues leading to a decreased expression. Bitot spots and vitamin A deficiency. Decrease in differentiation of epithelial cells into specialized tissue leads to conjunctival squamous metaplasia leading to keratin buildup. Wernicke encephalopathy in patients with alcohol use disorder given glucose. Thiamine deficiency leads to an impaired glucose breakdown. This ATP depletion is worsened by glucose infusion. Okay, fair enough. Pellagra in malignant carcinoid syndrome. Tryptophan is diverted towards the serotonin synthesis by the tumor, leading to B3 deficiency. B3 is derived from tryptophan. Okay. So you can get like a B3 deficiency as a consequence of it being diverted for serotonin synthesis by the tumor. So that's interesting. You can have like a pellagra not because of the consumption is bad, like you don't have enough B3 getting into your system, but you're just literally diverting it for other purposes because of a cancer. Kwashiorkor protein malnutrition leads to a decrease in plasma oncotic pressure, leading to edema, leading to a decrease in apolipoprotein synthesis, leading to fatty changes in the liver. Okay. Lactic acidosis, fasting hypoglycemia, hepatic steatosis in patient with alcohol use disorder. The mechanism is increasing NADH/NAD+ ratio due to the ethanol metabolism. Okay. So lactic acidosis, fasting hypoglycemia, hepatic steatosis in patients with alcohol use disorder. Okay, fair enough. Aspirin-induced hyperthermia. An increase in permeability of inner mitochondrial membrane leads to a decrease in proton gradient and an increase in O2 consumption, uncoupling, leading to heat production. Hereditary fructose intolerance. Aldolase B deficiency, fructose 1-phosphate accumulation, leading to a decrease in available phosphate, causing an inhibition of glycogenolysis and glyconeogenesis. Okay, let's continue. Essential fructosuria. Fructokinase deficiency leads to an increase in fructose, hexokinase pathway, and converts fructose to fructose 6-phosphate. Classic galactosemia. Galactose 1-phosphate uridyl transferase deficiency leads to an accumulation of toxic substances, that is to say, galactitol, in eye lenses, leading to cataracts. Galactokinase deficiency. Galactokinase deficiency leads to an increase in galactose. Aldose reductase converts galactose into galactitol. Okay, so let me again. Galactokinase deficiency leads to an increase in galactose. Okay. Aldose reductase converts the galactose to galactitol. Okay. Cataracts, retinopathy, nephropathy, peripheral neuropathy, and DM. So what's the mechanism behind all that stuff? Well, excess glucose means sorbitol via aldose reductase, and sorbitol leads to fructose via sorbitol dehydrogenase. Lens, retina, kidney, and Schwann cells lack sorbitol dehydrogenase, which means that the intracellular sorbitol accumulates, leading to osmotic damage. So basically, it's being mediated via osmotic damage because they don't have a way to deal with the sorbitol buildup. Recurrent Neisseria bacteremia. Terminal complement deficiencies of C5 through C9 leading to a failure of MAC formation. Yeah, so basically how that works is that you need C5 through C9 to make the MAC complex to attack Neisseria meningitidis or Neisseria gonorrhea. And if you can't do that, well, then you can have just a constant recurrent Neisseria infections because your body can't effectively deal with the matter afoot. Let's see. Okay. Well, that's good. I'm just checking up to see. Let's go back to it. Good. Okay. So let's go back to it. Okay. Okay. Hereditary angioedema. Chloride inhibitors, hereditary angioedema, chloride inhibitory deficiency, unregulated activation of kallikrein leading to an increase in bradykinin. Paroxysmal nocturnal hemoglobinuria. PIGA gene mutation leads to a decrease in GPI anchors for complement inhibitors. DAF over CD55, MERL over CD59 leads to a complement-mediated intravascular hemolysis leading to a decrease in haptoglobin. Paroxysmal nocturnal hemoglobinuria. I forgot exactly how this works. They're saying it's a GPI decrease issue, isn't it? Okay. I'm trying to figure this out. Okay, yeah. Complement-mediated intravascular hemolysis. Okay, fair enough. Type 1 hypersensitivity. Now, this is important. Immediate minutes, antigen crosslinks, IgE on mast cells, causing degranulation or leading to a release of histamine, tryptase, leukotrienes. Late, hours, mast cells secrete chemokines, attracts inflammatory cells and other mediators, leading to inflammation and tissue damage. Type 2 hypersensitivity. Antibodies bind to cell surface antigens or ECM, leading to inflammation, cellular destruction, and dysfunction. Antigen-antibody complexes activate complement, leading to attracting neutrophils to release lysosomal enzymes. Okay. Did I read that right? Okay. So type 2, antibodies bind to cell surface antigens or ECM, inflammation, cellular destruction, and dysfunction. Okay, fair enough. Type 3, hypersensitivity. Antigen-antibody complexes activate complement, attracts neutrophils, releases of lysosomal enzymes. Okay, fair enough. Type 4, hypersensitivity. T-cell mediated, no antibodies involved. APCs activate CD4 positive T cells, leading to a release of cytokines or CD8 positive T cells, direct cell cytotoxicity. So I want to go through that, just like a brief rundown for everybody who's listening. Type 1 hypersensitivity, that is like an allergic reaction. So if let's say I am allergic to peanuts, for example, as a hypothetical. I'm allergic to some sort of food. The body says, oh, this is foreign, this is alien, we're going to release, or let's say it's like a parasite. Parasite would maybe another example too. Like a parasite in the body, whatever, something like that. You're going to have, or some kinds of allergic reactions that are very fast acting, or a parasite, that kind of stuff. Or you have hay fever, like you have that kind of allergies. You will have IgE inducing this IgE immunoglobulin, right, inducing mast cells to degranulate and release histamine and other vasoactive substances. And so that's what's going on with a type 1 hypersensitivity. Think IgE, think mast cells, think degranulation, histamine release, vasoactive, think allergies, think parasites, that kind of thing. Type 2 hypersensitivity, that is going to be, I would think in that context, think about hemolytic anemia. In that context, think about hemolytic anemia as one of the possibilities. We talked about that. It is mediated by T cells still, but it's not exactly the same thing. So it's somewhat different. Now, type 3 hypersensitivity, we're talking about, or maybe say type 2, for example. Type 2, we could say maybe like an IgG, IgM, that kind of stuff. Not IgE necessarily, but IgG, IgM. A little bit more normative, you could say. Now, type 3 hypersensitivity is more about, it's more of an antibody-antigen thing. So let's say, for example, Goodpasture syndrome, that should be a type 3 because, no, bad example. I'm thinking about MSPGN. I'm thinking about, or PSGN, post-streptococcal glomerulonephritis. That is an example of an antigen-antibody complex being an issue. So when you think about that, think about type 3, think about antigen-antibody complexes accumulating somewhere. So that'd be like, again, post-streptococcal glomerulonephritis. For type 2, think about like a hemolytic anemia. You might want to think about something like, what's a good example? Maybe Goodpasture syndrome would be a good example. Maybe like, what's it called? Graves' disease would be an example. Myasthenia gravis would be an example. Those are examples of antibodies attaching to either, and let's say, for example, myasthenia gravis, we're talking about antibodies binding to the acetylcholine receptor. We're talking about Graves' disease, we're talking about an antibody attaching itself to like TPO or TSH receptor or something like that. We're talking about something, well, that TPO is going to be, now I'm thinking about something else, okay. But TSH receptor may be for something like Graves' disease, right? We're talking about, it's still antibodies, but it's IgG and IgM antibodies for type 2. For type 1, it's IgE antibodies, more like an allergic reaction. Type 3, that's more of a that's more like a PSGN, or like a post-streptococcal glomerulonephritis kind of situation, where it's like an antibody antigen complex is causing it. And then finally, for the fourth kind, it's not even T cells. It's not even B cells. It's not even like it's not these antigen antibody. It has nothing to do with antibodies really. It's all about T cells. And so a better example of that, for example, would be something like and we're talking type 4. I would talk about something like Hashimoto's at that point, I believe. Let me just make sure that I want to make sure I'm not incorrectly reporting that. Is Hashimoto's type 4? I think so. Yes, Hashimoto's thyroiditis is primarily considered a type 4 hypersensitivity. Good. Okay. So I wanted to confirm. Yeah, okay. So we'll continue. But that's an important concept, because you're going to get questions that relate to some sort of reaction like that. Also, by the way, type 4 includes things like poison ivy. Poison ivy is actually a type 4 hypersensitivity. And I think certain kinds of rashes in the body, like, let's say, for example, let's say you have a rash on your body because of the belt buckle or something is causing you to get irritated, irritates your skin. That's a type 4 hypersensitivity. Acute hemolytic transfusion reaction. Type 2 hypersensitivity reaction against donor RBCs, usually ABO antigens. Again, so that's example, hemolytic anemia. Probably think about type 2 hypersensitivity. X-linked Bruton A-gamma globulinemia. Defect in the BTK gene, no B cell maturation, absent B cells in peripheral blood, leading to a decrease in immunoglobulin of all classes. DeGeorge syndrome. 22q11 microdeletion, failure to develop third or fourth branchial pharyngeal pouches, leading to an absent thymus and parathyroid. Hyper-IgM syndrome is a defective CD40L on TH cells, leading to class switching defect. And another thing too, when you see something like a situation where you have normal or elevated IgM, and it's X-linked, it's in boys but not necessarily in girls, that's going to be a hyper-IgM syndrome. But there's a similar kind of presentation in terms of like, oh, well, the IgM is normal or elevated, but it's equally common in both boys and girls. There's no X-link to it at all. That's going to be AID. So, if I'm not mistaken, yeah, I believe so. If it's AID, if it's not X-linked, but if it is X-linked, then it's hyper-IgM syndrome. Leukocyte adhesion deficiency type 1. LFA1 integrin CD18 defect leading to an impaired phagocytic migration and chemotaxis. Chediak-Higashi syndrome. LYST list mutation, microtubule dysfunction leading to phagosome-lysosome fusion defect. Basically, there's a microtubule issue that prevents it from being able to actually fuse the phagosome and the lysosome, and so as a consequence, let's say, for example, your cells, like a phagocytic cell, like a macrophage, consumes a pathogen. It consumes like a bacteria or something like that, and it's in the phagosome. And then normally what's going to do is combine it with the lysosome to destroy, using bleach or other kinds of dangerous substances, kill the bacteria, kill the pathogen. Well, if there's a Chediak-Higashi syndrome, you have no microtubules to help fuse those two things, and so you're just kind of stuck with this with these pathogens in your phagosomes, and you can't do anything about it. Very unfortunate situation. Now, chronic granulomatous disease, or called CGD, NADPH oxidase defect leading to a decrease in reactive oxygen species, leading to a decrease in respiratory burst and neutrophils, leading to an increase in susceptibility to catalase-positive organisms. Very true. Now, I'm just going to go scroll down because I'm not sure if we're going to find anything that's still up to date on that. I don't know. But with this is another good point. So basically, NADPH oxidase helps convert oxygen, which is normal, like O2, into superoxide. And that's the first step into eventually creating bleach, which is made, I believe, from hydrogen peroxide, and then via MPO or myeloperoxidase it becomes bleach. Now, those are a lot more. That's a lot stronger substance, and so you can't make any of that stuff. Now, there are bacteria that do make some of those compounds. Some of them do make these more reactive oxygen species, not bleach typically, but some of the other things like, let's say like hydrogen peroxide, for example. They might make hydrogen peroxide. The body can actually instrumentalize and exploit that bacterial hydrogen peroxide for its own purposes to kill bacteria, but species that are catalase positive can destroy that and prevent that from happening. And so species like that would be, I think Aspergillus is one example of that. I have a list of them. Let me look it up right now, or I could just look it up from my thing right here. I have a lot of different notes, so I'll just go for my notes right now for bacteria that are actually catalase positive. Let's go through my bacteria list right here. Here we go. So catalase positive organisms that I can think of just from my notes here. Listeria monocytogenes is one. Nocardia is catalase positive. Both Staph epidermidis and Staph saprophyticus are catalase positive. E. coli can be catalase positive. Pseudomonas aeruginosa is catalase positive, of course, and Helicobacter pylori also likewise is catalase positive. Also, Bordetella pertussis is catalase positive. And I think there's some others as well. I didn't mention Aspergillus in that list, but I think Aspergillus is also catalase positive typically. Let me check. Aspergillus catalase positive. Yeah, it is. And I think there's probably even more than that, but just be aware of that because they might ask you a question about that, asking about which ones are actually catalase positive. Those are the ones you want to consider. I would look that up online just to see a more comprehensive list. Now let's continue forward. So next one is Candida infection immunodeficiency. A decrease in granulocytes systemic leading to, and as well as a T cell decrease in T cells, which is local. So you have a systemic decrease in granulocytes and a local decrease in T cells leading to Candida infections. Fair enough. Graft versus host disease. A type 4 hypersensitivity reaction, HLA mismatch leading to a donor T cell attacking the host cells. So the donor T cells are actually attacking the host, which is kind of an interesting one. Recurrent Staph aureus, Serratia, B. cepacia, infections in CGD. Okay, now we're going into it. Okay. Catalase positive organisms degrade, I believe that is hydrogen peroxide, before it can be converted into microbicidal products by the myeloperoxidase system. So basically, I described it and then they wrote it down, basically. Okay, great. Hemolytic uremic syndrome. Shiga/Shiga-like toxins inactivate the 60S ribosome, which would lead to an increase in cytokine release. Fair enough. Now, it says Shiga/Shiga-like toxin. So there is a Shiga toxin that does this, right? It says HUS. There's also a Shiga-like toxin that exists in E. coli. I think it's called EHEC, E-H-E-C. Now, E. coli has multiple toxins, just confirm that. But EHEC is the other toxin, I believe it is. Again, let me just double check. Is EHEC Shiga-like? Yes, it is. Cool. So let's continue. Tetanus. Tetanospasmin cleaves snare, this is capital S-N-A-R-E, leading to an inhibition of release of inhibitory neurotransmitters, GABA and glycine from the Renshaw cells. Again, if you know anything about GABA is trying to kind of reduce, the kind of keep things on the down low, keeps things kind of cooled down, if you will, for lack of a better term off the top of my head. And so if you have a situation where you can't release GABA, it's going to lead to because it's inhibitory, right? It's going to cause hyperpolarization via the chlorine channel, typically. So if you can't do that, then you're going to have this sort of hyperexcitable state, and so you induce tetanic paralysis. It's not a flaccid paralysis. That's like the case of botulism. Tetanus toxin causes a tetanic or spastic paralysis because it's overstimulated. Now on to botulism. Toxin protease cleaves snare, leading to a decrease in neurotransmitter, ACH, release at the NMJ, neuromuscular junction. So again, in this case, it's preventing the release of acetylcholine, and so it causes a flaccid paralysis. Causes the opposite effect. But they're both, at the end of the day, they're both different kinds of paralysis. And funnily enough, tetanus and botulism, both of these diseases are caused by Clostridium species. So one of them is called Clostridium tetani, and another one is called Clostridium botulinum. So next is gas gangrene. Now we're just going through the whole list of Clostridium species. Now gas gangrene, also caused by Clostridium perfringens, I believe. Yes. So gas gangrene, alpha toxin, a phospholipase lecithinase, degrades phospholipids, leading to myonecrosis and crepitus. True. Toxic shock syndrome, scarlet fever. TSST1 and erythrogenic exotoxin A cross-links beta region of TCR to MHC class 2 on APCs, antigen-presenting cells, outside of the antigen binding site, leading to a significant increase in IL-1, IL-2, interferon gamma, and TNF alpha. So a kind of a very serious response you're going to see. Next, shock and DIC caused by gram-negative bacteria. Lipid A of the lipopolysaccharide macrophage activation of TLR4 and CD14 complement activation, tissue factor activation. And just keep in mind, by the way, that the actual thing that LPS is triggering is TLR4, and then the LPS is a thing characteristic of gram-negative bacteria. Prosthetic device infection by staph epidermidis, biofilm production. Okay, yeah, because it forms a biofilm, and that's how it is able to colonize certain areas near the heart on these devices. Endocarditis secondary to S. sanguinis. Dextrans, I think this has to be referring to strep at this kind, strep sanguinis, because it sounds very much similar to how viridans works. So it says dextrans biofilm production. Fibrin platelet aggregates binds to damaged heart valves. Yeah, so that sounds very much like how viridans works. I'm not sure if sanguinis is a type of viridans or not. Let me see. Is S. sanguinis a type of viridans? Yes, it is. It's also called, so Streptococcus sanguinis, also formerly S. sanguinis, is a well-known member of the viridans group. Okay, cool. They always kind of conflate all of that together as a single thing. They say, oh, there's strep viridans, strep sanguinis, strep. There's another one I'm trying to think off the top of my head. There's another term for it. They want to call it, when they talk about dental caries, they like to call it that. But all that's, I guess, technically the same thing, or kind of the same family of stuff. Next, pseudomembranous colitis, secondary to C. difficile. Okay, toxins A and B damage enterocytes, watery diarrhea is caused by it. Now, they like to be very specific about it, and they talk about, A toxin and B toxin are totally different things, guys. A is all about, inducing a sort of effect that is going to cause the diarrhea, but the B toxin for difficile is kind of like cytotoxic. It's kind of like destroying things like the microtubules or whatever. It's the stuff inside the cell itself. And that eventually has, long run, has the same effects. They work hand in glove, complementary to each other to induce this really nasty kind of diarrhea. But at the end of the day, they are going to have, as a whole, the same effect of diarrhea. Together, they're combined, they cause that effect of watery diarrhea. But you might want to know the specific differences between those two different toxins. Diphtheria. Diphtheria, exotoxin inhibits protein synthesis via the ADP ribosylation of EF2, possible necrosis. Keep in mind, by the way, that the diphtheria toxin has an analogous toxin found in, I believe, Pseudomonas. So just keep that in mind as well. Virulence of M. tuberculosis. The cord factor activates macrophages, promoting granuloma formation, induces release of TNF-alpha. Sulfatides, surface glycolipids, inhibit phagot lysosomal fusion. So that's very important to know. The cord factor causes the granuloma to form, but the sulfatides prevent the actual M. tuberculosis from being destroyed from phagot lysosome fusion. Tuberculoid leprosy. Th1-mediated immune response, mild symptoms. Lepromatous leprosy. Predominantly Th2 response can be lethal. Yeah, so basically, a better way to phrase, they say Th1 versus Th2. That's true. Th1 is tuberculoid, Th2 is lepromatous. But Mycobacterium leprae, if you have a good, strong immune response, you'll probably have the tuberculoid form. And if you have a kind of a bad immune response, not very impressive, very weak, you'll probably have the leproid, the lepromatous form. That's like the actual, when people think about leprosy, it's the lepromatous form. It's the really nasty stuff that can really just, kill you, essentially. It's not good. It's very bad. So bear that in mind. So, and along with that, it's not necessarily, it's kind of a spectrum. Yeah, but it is kind of like a spectrum in truth. But yeah, it is more Th2 for the lepromatous form. Lack of effective vaccine for N-gonorrhea. Mechanism is antigenic variation of pilus proteins. Cystitis and pyelonephritis secondary to E. coli. Fimbriae, P. pili. Pneumonia, neonatal meningitis secondary to E. coli. It's from the K capsule. Chlamydia resistance to beta-lactam antibiotics. Lack of classic peptidoglycan due to a reduced muramic acid. Okay. Influenza pandemics. This is caused by an RNA segment reassortment antigenic shift. Influenza epidemics. Mutations in hemagglutinin, neuraminidase leading to an antigenic drift. And so this is really important for influenza A. In this context, they say influenza A and this is a influenza, but influenza A is able to actually experience shifts. Both of them can experience drifts, but only the influenza A can experience shifts. Basically, I'll try to explain it like this. Let's say, for example, we have a virus species that just kind of hangs out, it reproduces, whatever, and let's say it's only in humans. Okay, you're going to have antigenic drift. It's going to slowly kind of change over time. Antigens are going to change, and so the body, it's going to always be able to kind of stay kind of competitive, even though there's going to be vaccines or like immune responses to previous, flu seasons or whatever kind of virus you might have in previous infections and stuff like that. It will be able to keep itself around for a while, right? Now, let's say, for example, that same species has a related species or stock in a different animal. Let's say it's pigs, as an example. Well, that can be a problem because now that species, if there's a like a mixture between the two, where the species in the humans somehow it gets DNA and therefore a phenotype derivative of another species, but it still is able to infect humans, that's a problem because now we have a DNA or a phenotype from a completely different species from the virus in a completely different species now going into humans that we have no familiarity with, and that leads to an actual pandemic. So pandemics are caused by antigenic shifts, likely from a different population that we didn't have any sort of previous background with because it's from a different reservoir population. But an antigenic drift is simply the more normative mutations you might have because of the fact that you're getting it. It just slowly it changes over time, anyways, because of just normal antigenic mutations and variation. Now if you want to think about pandemics, for example, think about, let's say, the H1N1, right? Think about coronaviruses, and not a bad example either, because coronaviruses have been in with people for a very long time. However, when we talk about the COVID-19 pandemic, we're talking about something that is a recent development from a population that was probably not human. If we're talking about, I can't speak as to the specifics of its origin, but I would suspect that it's probably from a non-human population that came to human beings zoonotically. And we just didn't have any sort of background with that particular variety of the virus initially, and as a consequence, it led to a pandemic, essentially. Anyway, let us continue. CNS invasion by rabies. Binds to the ACH receptors, it leads to retrograde transport dynein, yeah. It leads to retrograde transport, yeah. HIV infection. Binds to the CD4 along with CCR5 on macrophages early, or CXCR4 on T cells, which is late. So bear in mind, early on in CD4 cells, it's CCR5 on macrophages. Later on, it becomes CXCR4, so more on T cells, which is a more chronic indication of a HIV infection. Granuloma. Macrophage-present antigens to CD4-positive T cells and secrete IL-12, leading to CD4-positive differentiation into Th1. Interferon gamma secretion leads to macrophage activation. Okay, sure. Basically, a granuloma is one of the ways the body responds to a foreign entity like a pathogen. It says, oh, okay, we're going to go from a granuloma to just kind of section things off because we really can't deal with it otherwise. Limitless replicative potential of cancer cells. Reactivation of telomerase maintains and lengthens telomeres, prevention of chromosome shortening and aging. Tissue invasion by cancer. A decrease in E-cadherin function leading to a decrease in intercellular junctions, leading to basement membrane and ECM degradation by metalloproteinases. Cell attachment to ECM proteins, laminin, fibronectin, leading to locomotion, leading to vascular dissemination. I want to go over that a little bit again. This is basically, how does a cancer invade something? Well, the E-cadherin is going to lose its function. Then you're going to actually have a decrease in intercellular junctions. Eventually, the basement membrane itself and the ECM degrade by the metalloproteinases. So now it starts kind of invading, right, the basement membrane. Cell attachment to ECM proteins, laminin, fibronectin. Okay. It starts moving, locomotion, right, and then eventually vascular dissemination. So basically, it's slowly kind of breaking down these barriers, crossing through until it can finally get through, and then it disseminates across the system, and then you're not in a great spot, you know. Okay. Let me take a short, brief break, if I can. Okay. Let's continue. Conditions and mechanism. Persistent truncus arteriosus, PTA, right? PTA. Failure of aorticopulmonary septum formation. Okay. Basically, the idea is this. Normally, what's going to happen is you're going to have a pulmonary trunk, and that's going to be the blood that's going from the heart to the lungs. Yes, from the right ventricle. And the aorta, which is going from the left ventricle over to the general systemic circulation. Now, there's supposed to be an intraventricular septum that develops between those two. An aorticopulmonary septum. And if it doesn't develop, well, that's called a persistent truncus arteriosus. D, transposition of great vessels. D in this case means, I believe, dextro, which just means that it's inverted, essentially, it's reversed. A failure of the aorticopulmonary septum to spiral. Oh. Okay, so it just means a failure of the aorticopulmonary septum to spiral. Okay, fair enough. TET spells in tetralogy of Fallot. I'm not sure what that means. Crying, fever, exercise, leading to an increase in right ventricular outflow obstruction, leading to a right to left flow across VSD. Okay. Eisenmenger syndrome, uncorrected left to right shunt, leading to an increase in pulmonary blood flow, leading to a remodeling of vasculature, leading to pulmonary hypertension, eventually causing a right ventricular hypertrophy, and eventually a right to left shunting. Basically what happens is that because it's so long you've had this left to right shunt, the right ventricle has had to hypertrophy to compensate, and eventually you get to the point where you actually have a right to left shunt because the right ventricle becomes more dominant, essentially. Atherosclerosis, endothelial dysfunction, endothelial cell dysfunction leading to a macrophage and LDL accumulation, causing foam cells to form, leading to fatty streaks, smooth muscle cell migration, leading to ECM deposition, fibrous plaque buildup, and eventually a complex atheroma, or complex atheromas. Thoracic aortic aneurysm. Thoracic aortic aneurysm, okay. Cystic medial degeneration associated with thoracic aortic aneurysm, cystic medial degeneration associated with tertiary syphilis. MI, myocardial infarction, rupture of the coronary artery atherosclerotic plaque leading to an acute thrombosis. Now we have two different things. We have an N-STEMI and an STEMI. So this is a non-ST elevated MI. This is a subendocardial infarct. And an ST elevated MI, which is a transmural infarct. And so, as a basic to this, if you have a transmural infarct, all three layers are messed up. They're all infarcted. You will have an ST elevation. Okay? If you only have the endocardium or a subendocardial infarct, then you actually will have typically an ST depression, which they call an N-STEMI. They say non-ST elevated, but typically it will be an ST depression, actually. Just keep that in mind. When they say STEMI, think transmural, think all three layers. When they say N-STEMI, think only subendocardial. Yeah, I'm sure there's a lot of content. I'm looking at the PDF right now. There's a lot of content overlap. It's just that the organization is completely different, it looks like, as far as I can tell. Death within 0 to 24 hours post-MI. That's because of ventricular arrhythmia. Right. Death or shock within 3 to 14 days post-MI. Macrophage-mediated ruptures, papillary muscles 2 to 7 days. Interventricular septum 3 to 5 days. Or free wall 5 to 14 days. So that's a interesting one. If you have a heart attack and it's been a day, you might think, oh, I'm out in the clear. You're not. Actually, there's a very good chance you just actually die from some other reason. You could die from papillary rupture. You could die from the septum rupture. You could die because of a free wall rupture. A lot of different ways things can go wrong. So just keep that in mind. Wolff-Parkinson-White syndrome. Abnormal accessory pathway from atria to the ventricle bypassing the AV node leads to ventricles to begin to partially depolarize earlier, creating a delta wave, reentrant circuit, supraventricular tachycardia. Hypertrophic obstructive cardiomyopathy, or HOCM. Sarcomere protein gene mutation leading to a concentric hypertrophy. Okay, sarcomeres added in parallel. Death due to arrhythmia. Okay, sounds interesting. Syncope, dyspnea, and HOCM. Asymmetric septal hypertrophy, systolic anterior motion of mitral valve leading to an outflow obstruction. Hypovolemic shock. A decrease in preload leads to a decrease in SV. I would assume that, what is that, systemic volume? I'm not quite sure what that means. Decrease in cardiac output. Let me read that again. Hypovolemic shock. So you have low volume. Decrease in preload leads to a decrease in stroke volume leading to a decrease in cardiac output. Very true. Cardiogenic shock. A decrease in cardiac output due to a left heart dysfunction. True. Obstructive shock. A decrease in cardiac output due to a blockage of vessels structures outside of the heart. True. Distributive shock. A decrease in systemic, SVR. Decrease in SVR. Whoops. I want to make sure that I'm not confusing that for something else. SVR. Okay, yeah. Well, systemic vascular resistance. Okay, fair enough. So let me go back to it. Okay, so back into that distributive shock, a decrease in systemic vascular resistance, afterload. Yeah, afterload. That's how I always refer it, afterload. Okay. Now, rheumatic fever. Antibodies to the M protein. By the way, M protein is from strep pyogenes, group A strep. So, rheumatic fever, antibodies to the M protein from group A strep cross-react with self-antigens. Type 2 hypersensitivity reaction. DVT, or deep vein thrombosis. Stasis, hypercoagulability, endothelial damage, Virchow triad, leading to a blood clot within the deep vein. Most common congenital adrenal hyperplasia. Euvolemic hyponatremia and SIADH. Let me go back. Most common congenital adrenal hyperplasia. Let me go back. Most common congenital adrenal hyperplasia. 21-hydroxylase deficiency leading to a decrease in mineralocorticoids, a decrease in cortisol, an increase in sex hormones, and an increase in 17-hydroxyprogesterone. Euvolemic hyponatremia and SIADH. An increase in ADH leads to a greater degree of water retention, leading to a decrease in aldosterone, leading to an increase in AMP, an increase in water retention causes a decrease in aldosterone, an increase in AMP, an increase in BNP, and which leads to an increase in urinary sodium secretion. That makes sense. ADH increases, now you have more water. Now the body says, we need to reduce our aldosterone and increase our BNP and ANP. That makes sense. And that's an important thing to note, because usually when we talk about a lot of water excess, one of the things we have to keep in mind is that typically when the body is absorbing water in the renal system, in the nephron, it's doing it by taking up sodium. So let's say, for example, in the PCT or in the loop of Henle or the DCT or whatever, when you're absorbing water, you're absorbing it by taking up sodium, and then the water will follow the sodium, it'll follow across that gradient. Now, ADH is unique because ADH encourages free water absorption at the collecting duct. So it's basically it's absorbing the water without necessarily absorbing the sodium. And as a consequence, you're basically putting yourself in a situation where you have hyponatremia while still having a normal or elevated, but typically normal, water concentration. Heat intolerance, weight loss, and hyperthyroidism. So, increase in sodium potassium ATPase, an increase in basal metabolic rate, leading to calorigenesis. Okay, so basically your basal metabolic rate is increasing because of the sodium potassium ATPase is increasing in degree. Okay, and it also probably means you have calorigenesis. You're losing calories as a consequence of that because it consumes ATP. Mixed edema and hypothyroidism. So increase in GAGs in interstitial space leads to an increase in osmotic pressure, leading to an increase in water retention. Graves' ophthalmopathy. Lymphocytic infiltration, fibroblast secretion of GAGs, leading to an increase in osmotic muscle swelling and inflammation. Okay. Next page. Condition, mechanism. Primary hyperparathyroidism. Parathyroid adenoma or hyperplasia leading to an increase in PTH, which is parathyroid hormone. Secondary hyperparathyroidism. A decrease in calcium and or an increase in phosphate leads to a parathyroid hormone hyperplasia leading to an increase in PTH and ALP. So basically, secondary hyperthyroidism is basically when the hyperthyroidism is secondary to a calcium deficiency or phosphate excess. Why? Because PTH is mainly focused on trying to increase serum calcium, and it also tries to decrease phosphate. I believe it encourages phosphate excretion in the kidneys. Vascular disease and DM and diabetes mellitus. Non-enzymatic glycation of proteins, small vessel hyaline arteriosclerosis, large vessel atherosclerosis. Diabetic ketoacidosis. A decrease in insulin or an increase in insulin requirement leading to an increase in lipolysis, an increase in free fatty acid oxidation leading to increase in ketogenesis. And that's going to increase how much acid is in the body. So it leads to a metabolic acidosis. Hyperosmolar hyperglycemic state. Hyperglycemia leads to an increase in serum osmolality, leading to excessive osmotic diuresis. Zollinger-Ellison syndrome. A gastronoma in the pancreas or duodenum, leading to a recurrent ulcers in the duodenum, jejunum, and malabsorption. Duodenal atresia. Recanalization failure. Basically, it's not able to recanalize, so it just stays atretic. It's not open normally. It's defective in that sense. Jejunal and ileoatresia. Disruption of mesenteric vessels, most commonly the SMA, leading to ischemic necrosis of the fetal intestine. Superior mesenteric artery syndrome. Diminished mesenteric fat leads to a compression of the transverse third portion of the duodenum by the SMA and the aorta. Okay. Achalasia. The generation of inhibitory neurons in the myenteric plexus of the esophageal wall, leading to a failure of lower esophageal relaxation. So the lower esophagus is basically unable to relax because of the neurons there, normally for encouraging relaxation and inhibition, just are degenerated. They're not there anymore. And so you can't necessarily swallow food the way you normally can. It would just build up in that area. So, Barrett esophagus. Chronic GERD leading to metaplasia of non-keratinized stratified squamous epithelium to intestinal epithelium, non-ciliated columnar of goblet cells. It's going from the squamous type to the columnar ciliated type, which is more characteristic of like something you'd find in the small intestine or something like that. Acute gastritis secondary to NSAIDs. A decrease in PGE2 leads to a decrease in gastric mucosal protection. Interesting. So, usually we associate PGE2 with fever and pain, but it is also true that PGE2, and we think about prostaglandins here, they encourage cytoprotection. And so if you don't have that because you're using NSAIDs to block that, well, you're going to have a decrease in cytoprotection of the gastric mucosa. And that's why sometimes we would use things that selectively bind to COX-2 as opposed to COX-1, because COX-2 doesn't necessarily have all those effects. It has some of the same effects, but it doesn't have necessarily the anti-cytoprotective effects. And I think that would include, I believe, celecoxib, I believe, is one of the things you would include. I think also acetaminophen. Does acetaminophen selectively bind COX-2? Yes. So acetaminophen, Tylenol, right, selectively binds to cyclooxygenase 2, which is important in this context. But cytoprotection is related to the cyclooxygenase 1. Just be aware of that, why NSAIDs cause that problem. Celiac disease. Celiac disease, autoimmune-mediated intolerance of gliadin found in wheat, leading to a malabsorption of distal duodenum, proximal jejunum, and steatorrhea. Fistula formation in Crohn's disease. Transmural inflammation. Okay. Meckel diverticulum is from a persistence of the vitelline or omphallomesenteric duct. Hirschsprung's disease. Hirschsprung's disease is the loss of the functional mutation in RET, leading to a failure of neural crest migration and causing a lack of ganglion cells or enteric nervous plexuses in the distal colon. And I think that means you're going to have a megacolon, if I'm not mistaken. Hirschsprung. I'm looking these things up like, is this Hirschsprung's disease causes a megacolon? And the answer is yes, I believe so. Is a Hirschsprung's disease or congenital aganglionic megacolon, because there's no nerves that's supposed to help move the contents of the bowels along. It just kind of builds up in there and creates a megacolon. Very nasty stuff. You can look, if you want to look that up, you could, but it's kind of an unfortunate situation. Adenoma carcinoma sequence in colorectal cancer. Loss of the antigen-presenting cell, decreased intracellular adhesion, causing an increase in proliferation, leading to a KRAS mutation, unregulated intracellular signaling, leading to a loss of tumor suppressor genes TP53 and DCC. So again, the order is this. You lose the APC, then you lose KRAS, then you have a KRAS mutation, then you lose this tumor suppressor genes TP53 and DCC. So again, APC to KRAS to TP53 and DCC. Keep that in mind, that order, okay? Fibrosis and cirrhosis occurs via stellate cell production of extracellular matrix. Rye syndrome. Aspirin decreases the beta oxidation via reversible inhibition of mitochondrial enzymes. Just keep in mind, if you have a child that has let's say they have influenza for some reason, they have a flu, they have something like that, and you say, oh, I want to give them something to reduce their fever, do not give them NSAIDs. It will cause them to have Rye syndrome, which can cause hepatotoxicity, and I think it can cause hepatitis and encephalitis, so just be aware of that. That's Rye syndrome. Hepatic encephalopathy. Cirrhosis leading to portosystemic shunts leading to a decrease in ammonia metabolism. Alpha-1 antitrypsin deficiency. Liver, misfolded proteins aggregate in the hepatocellular ER, leading to cirrhosis. Lungs, decrease in alpha-1 antitrypsin, leading to uninhibited elastase in alveoli, leading to pan-acinar emphysema. So that's alpha-1 antitrypsin deficiency. It messes with the lungs and messes with the liver, causing cirrhosis and pan-acinar emphysema. Okay. Wilson's disease. Mutated hepatocyte copper transporting ATPase, ATP7B, on chromosome 13, leading to a copper incorporation into the apocelluroplasmin, leading to excretion into bile, leading to an increase in serum ceruloplasmin, copper in tissues, and urine. And by the way, when it comes to Wilson's disease, a telltale sign of Wilson's disease, which I'll mention here, is Kaiser-Fleischer rings. You'll look at the eyes, and you'll see these, what you call Kaiser-Fleischer rings, because of the copper. Okay. Hemochromatosis. HFE mutation on chromosome 6, leading to a decrease in hepcidin production, an increase in intestinal absorption, leading to an iron overload, increasing ferritin, iron, but decreasing the TIBC, leading to an increase in transferrin saturation. So basically, hemochromatosis is an iron overload as a consequence of a increase in absorption, or a decrease, or a decrease in hepcidin production because of a mutation, basically HFE mutation. Gallstone ileus, a fistula between the gallbladder and the GI tract. Stone enters the GI lumen, leading to obstruction of the ileocecal valve, narrowest point. Yeah, so basically you have a relatively small space in the ileocecal valve, and so if the gallstone is big enough, it can cause a problem of obstruction. And how could that be possible? How could you have a gallstone that's so big that it blocks the ileocecal valve, but how could it possibly get out of the gallbladder itself because of the little space it has to get through otherwise? Because it is a fistula. Fistula allows it to go into the body anyways. Yeah. Acute cholangitis, biliary tree obstruction leading to stasis and bacterial overgrowth. Basically, the body is normally always bringing the material from the gallbladder down, down, down in one direction, unidirectional, away from the gallbladder itself. And so if you have an obstruction, well, that allows for colonization the other way around, leading to cholangitis. Okay, acute pancreatitis. Autodigestion of pancreas by pancreatic enzymes. Very nasty disease. Rh hemolytic disease of the newborn. Rh negative mother forms antibodies, maternal anti-D, IgG, against the RBCs of the Rh positive fetus. So that when you have your first pregnancy and delivery, it won't be a problem. But the second one, if there was no treatment for it initially, it will cause problems with the child. Let me look this up. What drug is used for Rh positive mothers? Rh negative mothers. Rogam, or Ro-D. It says here, Rh negative mothers are given Ro-D immune globulin, mostly commonly known as RhoGAM, to prevent sensitization against Rh-positive baby's blood. Yeah, so you would have to give that the first time around, but there wouldn't typically be an issue for the first child. It would be an issue for the second child. Again, unless the mother was treated with RhoGAM. Anemia and lead poisoning. Lead inhibits the ferrochelatase in the ALA dehydratase, specifically the delta ALA dehydratase, leading to a decrease in heme synthesis and an increase in RBC protoporphyrin. True. And it's just, lead is interesting because it affects both the ferrochelatase and also, again, this is here the ALA dehydratase. So, due to two different steps of the process, both an early step and a late step in the process of heme synthesis. Anemia of chronic disease. Inflammation leading to an increase in hepcidin, a decrease in the release of iron from macrophages, and a decrease in iron absorption from the gut. Now, the thing with chronic disease is that, it actually presents typically as like let's say you have a long chronic disease, eventually lead to something like a microcytic looking anemia. And you might be asking yourself, well, how could that be? Why is that the case? Well, as it says, the body doesn't really want the iron to be laying all around. It's going to try to sequester that iron, and it's going to try to lower absorption. And so as a consequence, if you are not absorbing the iron and you're trying to sequester it away from being available, well, then it's not available. And so you start developing a microcytic anemia as a consequence. And we're going to be going across some anemias right now as well. G6PD deficiency. So a G6PD deficiency leads to an NADPH decrease, leading to a reduced glutathione, leading to an increase in RBC susceptibility to oxidant stress. Okay, sure. Sickle cell anemia. Point mutation, substitution of glutamic acid with valine in beta chains, leading to a low O2, high altitude, acidosis precipitates sickling, polymerization of deoxygenated HBS, leading to anemia and vaso-occlusive disease. That's not great. And it's probably a very interesting example of how a point mutation can actually lead to a pretty radical change in the RBC morphology, so. Bernard-Soulier syndrome is a decrease in GP1B leading to a decrease in platelet to von Willebrand factor adhesion. Okay. And what's the actual presentation of that? It's kind of a little bit obtuse about that. Bernard-Soulier syndrome presentation. Presentation. So Bernard-Soulier syndrome presents as mucocutaneous bleeding, moderate to severe thrombocytopenia, and characteristic giant platelets. So again, there's an adhesion problem that's going on with Bernard-Soulier syndrome between the platelets and the von Willebrand factor adhesion, and it leads to all those kinds of problems. Now, Glanzmann thrombocytopenia is a decrease in the G2B3A, which leads to a decrease in platelet-to-platelet aggregation and causing a defective platelet plug formation. Now, thrombotic thrombocytopenic purpura, TTP, decrease in Adams TS13, which is a von Willebrand factor metalloprotease, leads to a decrease in degradation of von Willebrand factor multimers, leading to an increase in platelet adhesion and aggregation microthrombi formation. Okay. So Adams TS13 is kind of like moderating the effects of aggregation and adhesion. And so if you don't have that around, well, then you're gonna have this sort of microthrombi forming around when you don't want them to. Von Willebrand disease. So a decrease in von Willebrand factor leads to a decrease in platelet to von Willebrand factor adhesion, of course, possibly an increase in PTT. True. Von Willebrand factor protects factor 8. And how can you treat von Willebrand factor disease? You can give the patient, I think, desmopressin or vasopressin, so basically DDAVP or AVP, which is also, AVP is also ADH as far as I'm concerned. And that'll help kind of increase the release of von Willebrand factor, essentially, and factor 8. Factor 5 Leiden. Arginine 506, is that ARG 506 GLN? I want to make sure I'm saying this right. ARG 506 GLN mutation. So it's also called factor 5 Leiden. Okay, yeah. But what does the actual G technically stand for? It's is that glycine or is that what is that? Is that guan? No, that can't be guanine. Okay, well, I'm just looking. Listen. We're doing this on the fly. I'm learning with you right now, you know? It says here glutamine, sorry. So arginine 506 glutamine, mutation in factor 5, resistance to degradation by protein C, leading to a hypercoagulable state. So basically the way this works is this. Protein C and protein S promote, or let's say they inhibit the sort of this cycle of platelet aggregation and adhesion, that kind of process for fibrin formation. And so C and S are kind of like these moderating effects you typically have. But if you have a factor 5 laden issue, mutation of factor 5, it's going to cause a resistance to degradation by protein C, and it can cause a hypercoagulable state. Remember, factor 5 and factor 10 are used for converting factor 2 to factor 2A. I want to make sure I want to confirm that. Again, I have a large set of notes that I can go through, but I want to make sure that I'm not misspeaking when I say that. Here we go. Yeah, so basically, factor 5, along with factor 10, are used to convert factor 2, which is prothrombin, into factor 2A, which is thrombin, which is the active form. And this is obviously needed as part of the common pathway, and that's going to be inhibited. Factor 5 is going to be inhibited normally by active protein C. And so if you have a factor 5 mutation, that means, now I can't actually break down factor 5 like you normally would be able to degrade it. And so now you have a hypercoagulable state. Okay. Heparin-induced thrombocytopenia. Oh, this is fun. Paradoxical, Type 1, heparin administration within 2 days leading to mild transient drop in platelets, not clinically significant. Type 2, heparin administration 5 to 10 days, IgG antibodies against heparin-bound platelet factor 4 complex. Complex binds and activates platelets, leading to thrombosis, removal by splenic macrophages, decreasing platelet count, significant thrombocytopenia. So here's the idea with this. Heparin typically binds to antithrombin 3, and that'll mess with factors 10A and 2A. Basically, 10A and 2A would be thrombin. And so this is sort of an anticoagulant effect, typically with heparin. Now, if you have the antibody form against it, the IgG antibodies form against it, it'll actually activate the platelets, leading to a thrombosis, and then it will cause the thrombocytopenia afterwards because it's being removed by the splenic macrophages eventually. So it's not exactly an ideal situation. Now, warfarin-induced skin tissue necrosis. This is no fun either, for people who get it, of course. Warfarin administration, leading to a rapid decrease in protein C levels due to its shorter half-life, leading to a procoagulant state due to the delay and depletion of other existing clotting factors with longer half-lives, leading to a hypercoagulation and microthrombosis and skin tissue necrosis. So I want to go into that as well. So here's the thing with warfarin. Like heparin, warfarin is for anticoagulation typically. And let me see if I can find it right here. Here we go. And warfarin is for anticoagulation, but it messes with these factors: protein C, protein S, factor 2, factor 7, factor 9, and factor 10. Again, that's 2, 7, 9, 10. Now, 2, 7, 9, and 10 are part of the actual coagulation process. And so because warfarin messes with the reduction of vitamin K epoxide back into vitamin K reduced form, which allows for the activation of inactive coagulation factors via the gamma-glutamyl carboxylase, where they're carboxylated essentially, with the help of vitamin K. Because warfarin is knocking this process out, it inhibits VCOR, right? Because this is happening, you are going to eventually lose active forms of factor 2, factor 7, factor 9, and factor 10, but also protein C and protein S. Now, you might say to yourself, well, that seems fine because, I want to have anticoagulation, so I'm knocking out these anticoagulation factors. Well, protein C and protein S are anticoagulation. And the problem is that they get knocked out quicker than the coagulation factors do. And so you technically have a transitory, brief, hypercoagulable state with warfarin, which is a problem because if you're taking warfarin, because you're taking warfarin in the first place because you want to have anticoagulation, but you're telling me that you're going to have a hypercoagulable state briefly. Well, that could be a recipe for disaster, and that's why you could have something like a warfarin-induced skin tissue necrosis. Axillary nerve injury. Fractured surgical neck of anterior dislocation of the humerus leading to a flattened deltoid, arm at the side, decrease in shoulder sensation. So the shoulder thing is the easiest one. If your deltoid doesn't work, for example, and you can't, you don't feel a sensation around your shoulder, that's probably an axillary nerve problem. Or it could be a C5 issue as well, but, whatever. Radial nerve injury, Saturday night palsy. Axillary compression, use of crutches, midshaft humerus fracture, repetitive pronation, supination of the forearm, leading to wrist drop and a grip strength decrease. So if let's say you have a wrist drop and you have a decrease in grip strength, that's more likely to be a radial nerve issue. And that is going to be because of like a midshaft humerus fracture. So let's say you have a break in you have a fracture of the humerus, and it's kind of in the middle of the shaft. That's probably going to be a radial nerve issue. Median nerve injury, hand of benediction. Proximal lesion, supracondylar fracture, loss of the wrist flexion, and function of LOAF, loaf muscles, loss of sensation over the thenar eminence, dorsal and palmar aspect of lateral 3.5 fingers. Distal lesion leading to carpal tunnel syndrome. So, again, the presentation is a little bit different depending if it's a proximal or a distal problem. But just bear in mind, too, by the way, when you think about the nerves for the hand, the fingertips and the dorsum of the hand, especially the thumb and then the index, the pointer finger and the middle finger, those fingers are going to get sensation from the median nerve on the dorsal part of the hand, and the thumb is going to they're going to get a lot of innervation from that median nerve. The lighter two fingers, the ring finger and the pinky finger, those fingers are going to get innervation from both the anterior and posterior, both the palmar and the dorsal parts of the hand from the ulnar nerve. Okay, so just keep that in mind. Oh, I think I misspoke. Sorry, I'm thinking about radial nerve a little bit for the median nerve. Let me check this up again. Median nerve innervation, hand sensation. I think the palmar part's actually the median nerve. Yeah. Okay. The second answer that I have is right. Yeah, the palmar part of the hand. So let's say the palmar part of the thumb, pointer finger, middle finger, and part of the ring finger is the median nerve, and also the fingertips as well. The radial nerve covers the part of the hand that's behind that on the dorsal surface. But the ulnar part is basically that pinky finger plus part of the ring finger on that surface on both sides. So I would look at a diagram if I were you for that, but that's kind of how that works. And the best way, in my opinion, to think about, what nerve is possibly affected, think about, what areas are losing sensation. Is it just one? Is it the pinky finger? You have to think, is the pinky finger, is it C8? Is it the ulnar nerve, right? If you think it's the thumb, is it a C6 problem? Maybe it's a median nerve issue, Is it the dorsal surface? Maybe it's the radial nerve. If it's the palmar surface, maybe it's the median nerve. Is it just the middle finger? Maybe it's C7. Just think about what's being lost in the context of these things. Ulnar nerve injury, finally. Proximal lesion, fractured medial epicondyle, causing a radial deviation of wrist on the flexion. Yeah. Distal lesion, fractured hook of hamate, fall on outstretched hand, leading to an ulnar claw on digital extension, loss of sensation of the ulnar digits. True. And we're going to go into Erb's palsy a little bit. I'm going to take a short little break. Okay. So, I'm thinking about it right now. I think I want to continue with this a little bit, but because of how dense the material is in this chapter, it's not exactly the same thing as the previous chapter we talked about before, because it's not like a particular, one topic. We kind of slowly go through it, very narrative driven, very logical progression. This is a very condensed thing where it's very heavy, very, I feel like it needs a lot of explanation. And as a consequence of that, this is going to be a lot longer than what you would typically think, given how long the chapter is. So even if it's so, you say, it's only like about 30 pages, there's like a billion different pathologies mentioned on every single page that I feel, in many cases, the need to explain a little bit better than what they're explaining here. And unfortunately, because of the video and the time to actually read this much longer than it actually should be otherwise. So I might cut this early, or I might not. I'll have to see. But honestly, at this point, I've not covered very much material given the amount of time that I've actually done to cover it. So anyway, let's go through and continue. Erb's palsy, or waiter's tit. Traction/tear of the C5, C6 roots on the infant's neck during delivery or due to trauma in the adults. So basically, think about the space between your shoulder and your neck expanding a lot, maybe because you're through birth or because it's hard to think of an adult situation, but like some situation where somehow, for some reason, your neck and your shoulder, the space gets a lot wider for some reason. The other one is Klumpke's palsy, which causes a claw hand presentation. Traction/tear of C8T1 roots on the infant's arm during delivery or on trying to grab a branch as an adult. So the idea with this is that, let's say, for example, you're hanging from one arm on a jungle gym, and the area between your chest and your arm is much greater than it typically is. If you continue that for a very long time, and let's say in a traumatic situation, it can kind of tear or damage that C8T1 nerve roots. As a consequence, you get a claw hand presentation. So Erb's palsy is Wader's tip. Basically, what happens is your arm is medial. It's kind of like it almost looks like a guy is standing and trying to ask for like a little tip in a very informal sense, in a very keeping it very low key. And the other way, Klumpke's palsy is an actual claw hand presentation. So it's a little bit different in terms of how it looks. But thinking about Klumpke's claw hand, Erb's, I don't know. It's the Wader's hand. Also keep in mind, by the way, that Erb, the letter E is before K. And so you can remember that the Erb's palsy is caused by a higher level C5, C6 dysfunction, while Klumpke's is caused by the lower CAT1 dysfunction. And otherwise, it's pretty logical, but based on how you damage the nerves, of course. Now, winged scapula. Injury to the long thoracic nerve, C5 through C7, seen after mastectomy and stab wounds. Common perineal nerve injury. Trauma to lateral leg, fibular neck fracture, foot drop with steppage gait. Superior gluteal nerve injury. Iatrogenic injury during intramuscular injection in gluteal region, leading to a Trendelenburg sign, lesion contralateral to the side of the hip that drops due to abductor weakness. Pudendal nerve injury. Injury during horseback riding or prolonged cycling can be blocked during delivery at the ischial spine, leading to a decrease in sensation in perineal and genital area, plus or minus fecal or urinary incontinence. Which makes sense, because pudendal nerve is all related to that kind of stuff as well. Oh, that's another thing too. I'm thinking about hip drop. I'm going back to superior gluteal right now. Let's say, for example, I have a hip drop. I have a right hip drop. What does that mean? Well, that means I have a left superior gluteal problem. When you have a right hip drop, my hip is dropped on the right, my left side has a problem with it, okay? Bear that in mind. That's related to the this is abductor weakness. It's related to a left problem, like a left superior gluteal nerve problem. Mm-hmm. Now, radial head subluxation, nursemaid's elbow. Due to a sudden pull on the arm in children, radial head slips out of immature annular ligament. Okay. Slipped capital femoral epiphysis, or SCFE. Obese young adolescent with knee or hip pain, leading to an increase in axial force on the femoral head, leading to an epiphysis displaces relative to a femoral neck. And so the way I've heard this before is that it almost looks like when you look at a scan of the leg, it looks like almost like an ice cream cone. The ice cream is falling off the cone, slipping off the cone. That's what it kind of looks like. It's the actual trauma. It's literally called slip capital femoral epiphysis. Like the top of the bone of the femur is literally slipping off the femur body, the sort of the shaft of the femur itself. It's very weird looking. Now, achondroplasia, constitutive activation of the FGFR3, leading to a decrease in chondrocyte proliferation, leading to a failure of the endochondral ossification, causing short limbs. Okay. Osteoporosis, increase in osteoclast activity, leading to a decrease in bone mass secondary to decrease in estrogen levels, old age, and long-term use of medications like steroids. Okay. Osteopetrosis. Well, remember, petrosis means like stony or bone. So it literally means bone stone condition, basically. Carbonic anhydrase 2 mutations leading to the decreased ability of osteoclasts to generate an acidic environment, leading to a decrease in bone resorption, leading to dense bones prone to fracture, pancytopenia, or a decreased marrow space. So you might think to yourself, oh, wow, so the bones can't actually break down meaningfully because there's no osteoclasts that function really well. And so you're going to have, very dense bones. It must be very strong, right? Well, not necessarily, because it's more dense, sure, but it's not formulated in a way that ensures, maximum integrity. So it actually fractures. And because there's a very minimal marrow space, now you have like myelosuppression, basically. You have pancytopenia, Osteitis deformans, Paget's disease of bone. An increase in osteoclast activity followed by an increase in osteoblast activity, very true, leading to formation of poor quality fracture-prone bone. Now, tell me about this. So basically the idea for osteitis deformans is this, which is called Paget's disease. Well, your body has all this osteoclast activation, very serious stuff, is breaking down all the bone. That's not good. You want to have a moderate level of that. This is out of control. Well, how's your body going to respond? It's going to start activating all the osteoblasts. And so as a consequence of that, you have all this osteoblast activity and all this osteoclast activity. So the osteoblasts are able to kind of keep up with the osteoclast breakdown. The problem is that it's not very well made bone. Unsurprisingly, if you have a lot of cells that are rushing to make as much bone as possible to compensate for all this bone destruction, it's not very good quality. And as a consequence, you have a lot of poorly made bone, essentially, which is prone to fracture. Osteoarthritis. Mechanical degeneration of articular cartilage leading to an inflammation with inadequate repair and osteophyte formation. Rheumatoid arthritis. Autoimmune inflammation, pannus formation, erosion of articular cartilage and bone. Sjogren's syndrome. Autoimmune reaction, lymphocyte-mediated damage of exocrine glands. And that's why, for example, if you have Sjogren's disease, you might want to use like a muscarinic. I think a muscarinic would be the correct. Yeah, I think it's muscarinic to help encourage salivation because, well, you have a dry mouth, right? You have a dry mouth. Like you might have dry eyes as well. Let me confirm that. Sjogren's presentation. I want to make sure I'm not getting anything wrong. You have a sand in the eyes, dry mouth, fatigue, joint pain, dry skin. Yeah. So basically, all those glands that you need to produce things, they don't work. So you have a dry mouth, you have dry eyes, that kind of thing. Okay. Lupus, or SLE specifically, systemic lupus erythematosus. Predominantly a type 3 hypersensitivity reaction with a decreased clearance of immune complexes. Hematologic manifestations are a type 2 hypersensitivity reaction. So bear that in mind. When you think lupus, think it's primarily type 3 hypersensitivity. It's that antibody antigen complex formation. But in addition to that, there is some type 2 effects as well with the hematologic manifestations of it. Blindness in giant cell temporal arteritis. So again, blindness in giant cell arteritis, which is called temporal arteritis. Okay. Ophthalmic artery occlusion. Simple enough. The ophthalmic artery is not very big. So if you have a bunch of giant cells trying to get through it, it obstructs it. Now you can't see. That's too bad, Simple enough. Myasthenia gravis. Autoantibodies to postsynaptic nicotinic acetylcholine receptors. Again, that is going to be a type 2 hypersensitivity. Lambert-Eaton myasthenic syndrome. Autoantibodies to presynaptic calcium channels leading to a decrease in acetylcholine release. So again, it's called myasthenic syndrome, but it's not a matter of postsynaptic nicotinic blockage. It's a matter of presynaptic acetylcholine release being a problem by messing with the calcium channels. That's Lambert-Eaton syndrome in that case. Albinism, this is when somebody's albino, normal melanocyte number, but decreased melanin production. That's interesting. I didn't know that. I thought it might have been a melanocyte issue, but it's not. It's actually a melanin issue itself. Doesn't necessarily mean you have a melanocyte deficiency. Vitiligo. That's the disease that Michael Jackson is said to have. And the reverse of that is the one that I think Uncle Ruckus is supposed to have, if I'm not mistaken. But vitiligo, the real disease vitiligo, I think Michael Jackson did have that, to be fair. Vitiligo, autoimmune destruction of melanocytes. So in that case, it actually is a problem of melanocytes. So if let's say, for example, and this is true, there are people who are, let's say, typically more be darker featured, or of sub-Saharan Africa, some sort of other tropical climate. But you can see it in people who are obviously lighter skinned as well. You can have albinism. Again, you have melanocytes that just don't make melanin effectively. So that's albinism. But if you actually have vitiligo, your melanocytes are being destroyed. And so, yes, you will have almost like an albinistic appearance because you're not making melanin, but that's because you don't have the melanocytes in the first place anymore. And in the case of Michael Jackson, it almost has a kind of a piebald appearance to it, where it's kind of spotty and here and there, that kind of thing. Atopic dermatitis. Epidermal barrier dysfunction. Genetic factors like loss of function mutations in the filaggrin FLG gene, immune dysregulation, altered skin microbiome, and environmental triggers of inflammation. Okay. Allergic contact dermatitis. Again, this is type 4. So type 4 hypersensitivity reaction. During the sensitization phase, allergen activates Th1 cells, memory CD4 positive cells, and CD8 positive T cells cell formation. Upon re-exposure, CD4 positive T cells release cytokines, and CD8 positive T cells kill target cells. So just keep that in mind, that it's both CD4 and CD8 cells, both the helper T cells and the cytotoxic T cells are involved in this process. And keep in mind as well that this is the only hypersensitivity condition, type 4 hypersensitivity, that actually involves T cells rather than B cells. It's T cell mediated, not antibody mediated. So that's allergic contact dermatitis. Pemphigus vulgaris. Pemphigus vulgaris is a type 2 hypersensitivity reaction. IgG autoantibodies form against desmoglein 1 and 3 in desmosomes, causing a separation of keratinocytes and stratum spinosum from stratum basale, which is going to be a Nikolsky sign positive. Okay. The issue with this kind of stuff, for me, is that the stuff that I'm more familiar with, we start talking a lot about it. And the stuff that I'm less familiar with, I don't have really anything to say about it, of course. And, in all honesty, it's the things that I don't know about that I need to know more about, and vice versa, The stuff that I know, I don't really need to know it again. The stuff that I don't know, I need to read a little bit more about it, I suppose. And a little review probably doesn't do a whole lot for me, to be fair. But we'll see. Bullous pemphigoid. This is also a type 2 hypersensitivity reaction. IgG autoantibodies against hemidesmosomes, leading to a separation of epidermis from the dermis. It's going to be Nikolsky sign negative. So just keep it in mind, if it's bullous pemphigoid, it's Nikolsky sign negative. And if it's pemphigus vulgaris, it's Nikolsky sign positive. But they're both because of IgG autoantibodies. But the problem is that for vulgaris, it's going to be to the desmoglein 1 and 3. But for the bullous type of pemphigoid, it's going to be to the hemidesmosomes. Okay, spina bifida occulta, meningocele, myelomeningocele, and myeloschisis. Failure of caudal neurospore diffused by the 4th week of development. Now, there's a lot more to it than that, of course. You talk about there are differences between those different things, occulta, meningocele, myelomeningocele, and myeloschisis, but that order that I gave you is an order of severity. Spina bifida occulta, it's barely noticeable. You can barely see maybe like a tuft of hair, but that's about it. It's not really anything too serious. You might be basically asymptomatic and not having really problems with it. Myeloschisis is very serious stuff, the other end of the spectrum. So just keep that in mind. Very broad spectrum of presentations that we categorize all that stuff in. But it's a caudal neuropore fusion defect. And the other end of that, this is caudal. If you had a rostral, I think is the term. I think that's related to like something like an anencephaly. That's really nasty. That's is that right? I want to make sure. Rostral neuropore closure defect. That would be anencephaly, right? A rostral neuropore closure defect would be a result of failure of renal, leading to severe brain and skull malformations, leading to primary anencephaly. Yeah, exactly. So if you had to choose, I guess you'd probably prefer the caudal neuropore, because you'd rather have, I think you'd probably rather have a head than have a little issue of tuft of hair on the back of your spine, So it's a lot worse to have the rostral neuropore. But, again, there's a spectrum with the caudal neuropore from barely noticeable to very serious. Anencephaly. Oh, wait, great. Speak of the devil, I suppose. Anencephaly, failure of the rostral neuropore to close, no forebrain, open calvarium. That will lead you to be not being alive, essentially. It's not compatible with life. When you were born, you will not be alive. You'll be stillborn. So, deeply unfortunate situation in that case. Hollow prosencephaly. Failure of the forebrain prosencephalon to divide into the two cerebral hemispheres, developmental field defect typically occurring at weeks 3 and 4 development, associated with the SHH mutations. I'm reading that they're typically occurring at weeks 3 to 4, associated with SHH mutations. Okay. So this is basically, it doesn't develop its two normal hemispheres, two cerebral hemispheres. Okay. Lissencephaly, that's two S's, by the way. Lissenc, cephaly, right? Okay, whatever. Lissencephaly, failure of the neuronal migration leading to a smooth brain surface lacking sulci and gyri. Well, that can't be good. Chiari 1 malformation, downward displacement of the cerebral tonsils through the foramen magnum. That's not fun, that's not good. Chiari 2 malformation, herniation of the cerebellum, vermis and tonsils, and medulla through the foramen magnum. Likewise, not a good thing. Dandy-Walker malformation. This is kind of related to that as well. Agenesis of the cerebellar vermis, leading to a cystic enlargement of the fourth ventricle, which fills with enlarged posterior fossa. Syringomyelia. This is going into the spine now. Syringomyelia, a fluid-filled gliosis-lined cavity with spinal cord, damages crossing spinothalamic tract fibers. Yep. Cape-like loss of pain and temperature. It's kind of dependent. Basically, let's say, for example, the syringomyelia, when we're talking about that, we're talking about a damage to the center of the spinal cord. And so typically, it's not going to be, and a minimal is going to probably affect the spinothalamic tracts. Basically, you're going to have pain and temperature knocked out because they cross at the same level as that location of the spinal cord. So, for example, if you have a pain and temperature sensation at T6, it will cross over at T6 before it goes back up into the head, back into the brain via the spinal cord. Okay? That's different from the posterior column. That's different from the anterolateral pathway. They're not the same way. They do not cross over at the same level as they go out from the cord or go into from the cord. So the only thing that's going to be affected typically in a minimal would be that pain and temperature pathway. However, if the syringomyelia expands, it can affect the lateral horns, which it can cause in the thoracic region, which can cause something like a Horner syndrome, right? It messes with that sympathetic system. Or it can go even further and you start messing with the anterior horns, which cause motor weakness as well. That would be like a lower motor neuron problem as well. So just think of it. What matters is knowing how big it gets, essentially. But the minimum pain and temperature is going to be knocked out. Where are we again? Okay. Gerstmann syndrome. That's Gerstmann syndrome. Lesion in the dominant parietal cortex, agraphia, acalculia, finger agnosia, left-right disorientation. And when they say, oh, it's the dominant, what does it say? This is dominant parietal cortex. Most people, that's going to be the left parietal cortex. So when they say the Gerstmann syndrome is in the dominant, it's left parietal cortex for most people. There are some left-handed people who have a right dominant, but even like half of left-handed people still have a left dominant parietal cortex. And so when they say, so just want to think about how this logically. Let's say, for example, 90% of people are right-handed, 10% of them are left-handed. You might have 5% of people, maybe something like that, give or take, maybe another 5%. It could be it might be 2 to 15. I'm not sure. It's something like that. It's not a big deal. Very few people who have a right dominant parietal cortex. It's usually left dominant. So when they say Gerstmann syndrome, think a left parietal issue. Typically, they might have to specify in the question to be fair. Okay? And it leads to a lot of problems to it. It leads to agraphia, acalculia, finger agnosia, left-right disorientation. And if you have the issues on the non-dominant side, there are some issues too. Like you might not acknowledge one side of the image that you have. For example, let's say I have a damage to my right parietal cortex. I might not acknowledge the left side of my field of view. I might not acknowledge it at all. I might have some sort of dysfunction with it. But when it's the dominant side, you know, all these other problems associated with like acalculia, you can't calculate correctly, you can't draw correctly, you have finger agnosia, all these sorts of other issues that pile on top of it if it's the dominant cortex. So keep that in mind. Hemispatial neglect syndrome. Lesion in the non-dominant parietal cortex leading to agnosia of the contralateral side. Oh, wow, that's just described. That's great. Yeah, awesome. Cool. I love when I do this thing where I go on and on about something that's kind of vaguely related, but not necessarily the same thing. And the next part of the text is the same thing I just described in a little bit more concise detail. So, yeah. It's just that you don't acknowledge one side of your vision, field of view. The contralateral side, for reference. So if I have a right parietal issue, I won't acknowledge my left field of vision in a way that's normative, right? Kluver-Bucy syndrome. Bilateral lesions in the amygdala seen in HSV-1 encephalitis leading to a disinhibition including hyperphagia, hypersexuality, and hyperorality. Yeah, basically, the best way I can think of this, there's a couple of different ways I can think about it. Off the top of my head, I started already thinking about, might be not totally appropriate, but I hear Kluver-Bucy, I started thinking of John Wayne Gacy, just from briefly, the way the word sounds, I suppose. But it's not totally far off. You know, people with Kluver-Bucy syndrome, they basically have a very strong id, right? They have these sort of passions that are normally suppressed by the brain, you know, hypersexuality, for example, they want to eat, they want to have relations with people in a certain manner, this kind of stuff, and it's usually suppressed by the brain, by the what the Freudians might call the superego or something like that. But that's not really in play with somebody with Kluver-Bucy syndrome. They just do this kind of stuff. They don't really have a lot of inhibitions against doing it. And another good way of looking at it is like a drunk person. There are some people who, and this is usually true, in the moderate and more sensible thing, there's people who have to drink alcohol because if they don't, then they have all these inhibitions about, asking some girl out or doing something they otherwise wouldn't do, that kind of thing. And again, the more radical example, I give the example, going back into John Wayne Gacy, people like Jeffrey Dahmer, or maybe who was the one who was actually heterosexual? Which American serial killer was actually heterosexual? He was very famous. Let me look it up right now. American heterosexual serial killer. I'm sorry I don't know the name off the top of my head. Not Ted Bundy. Ted Bundy. Yeah, Ted Bundy, pretty famously, he had to get really drunk because when he did the crimes that he was committing a lot of the times, because he had a lot of inhibitions about doing them for obvious reasons. There's an obvious reason why your mind is telling you, hey, don't do what you're doing in this context, but he has a passion to do this kind of really messed up stuff. And so as an analogy for you, a Kluver-Bucy syndrome is like getting really, really drunk. It's like a person who is lacking any meaningful inhibition and is engaging in really kind of questionable behavior because there's no inhibition against it, essentially. And again, that's a bilateral lesion to the amygdala, right? Seen in the HSV-1 encephalitis. So again, it's kind of that situation. And remember, the amygdala is kind of like a fear response. And so it's kind of like you're trying to undermine your ability to restrain yourself, that kind of thing. Paranod phenomenon, or Paranod syndrome. Compression of the dorsal midbrain, often due to pineal gland tumors, leading to an upward gaze palsy, convergence, retraction, nystagmus, and light near dissociation. So remember, Paranod is a pineal gland tumor typically. There's an upward gaze palsy too with it. Cerebral edema, fluid accumulation in the brain parenchyma leading to an increase in intracranial pressure, may be cytotoxic or vasogenic. Aphasia. Stroke in the dominant, usually left hemisphere, in either the superior temporal gyrus of the temporal lobe with Wernicke receptive aphasia, or inferior frontal gyrus of the frontal lobe, leading to Broca's or expressive aphasia. I have a kind of a, it's not a mnemonic, but some sort of a strategy of words of how I can remember that kind of stuff. I don't want to share that because it's probably not not something that's probably going to want on YouTube, but it's a little unwoke. It's not exactly PC liberal, but no, seriously, what you have to remember basically is that for Wernicke's is going to be superior but posterior, right? In the temporal lobe, but it's comparatively posterior. It's behind the Broca's region, and it's in the temporal lobe, right? But the Broca's region, which is for expressive aphasia, think of Broca's broken speech. If you have a Broca's lesion, you have broken speech. You can't speak correctly. Broca's aphasia or Broca region is inferior, but it's technically in the frontal lobe. It's actually more anterior and in the frontal lobe, just for reference. Now, in all fairness, it's in the posterior frontal lobe, and the case of Wernicke's is in the anterior temporal lobe, I guess, kind of. But just remember that Wernicke's is superior temporal, and that Broca's is inferior frontal. Okay. And also for Wernicke's, it's a receptive aphasia, not a expressive. Expressive is Broca's, receptive is Wernicke's. Now, locked-in syndrome, stroke of the basilar artery, loss of horizontal but not vertical eye movements. So you can have you can't move your eyes back and horizontally, but you can move them up and down. Locked-in syndrome is pretty serious stuff. You don't want to get that. But yeah, you can have vertical eye movements though. Lateral pontine syndrome. Stroke of the anterior inferior cerebellar artery. Fair enough. Yeah, and I'm not going to go into rules of 12 necessarily here. That would be a good thing to review. If I were you, I would go look up right now, or maybe pause this video and whatever. Go look up rules of 12 for the brainstem and for the cranial nerves, and that's a very useful thing to understand lesions in those areas and what kind of presentation clinically you'll see. But yes, the lateral pontine syndrome is going to be a stroke of the anterior inferior cerebellar artery. Lateral medullary syndrome, which is called Wallenberg syndrome, is going to be, let me just guess. I'm going to try to guess. I'm not going to look at it right now. I think that lateral would be a pica issue. It would be a posterior inferior. Let me read this. Wallenberg syndrome, lateral medullary, would be a stroke of the posterior inferior cerebellar artery. Wow, I guessed it. That just goes back into rules of 12. Just read up on that. Very important stuff. I would look into that. Medial medullary syndrome. That's going to be, I think, an ASA one. This says stroke of anterior spinal artery. Yeah, ASA. Neonatal, and unfortunately, they don't say what does that actually imply, like what's the clinical presentation. That's more important, honestly. But that goes back into rules of 12. Look up rules of 12. Medial medullary, by the way, should be just cranial nerve 12, I think, for reference. Like a CN12 problem. Now, neonatal intraventricular hemorrhage. Reduced glial fiber support and impaired autoregulation of BP in the premature infants, leading to bleeding into the ventricles, originating in the germinal matrix, which is a highly vascularized layer within the subventricular zone. Now, epidural hematoma. Rupture of middle meningeal artery, often secondary to a skull fracture, involving the pterion. Very true. So when you think, I damaged the pterion, which is between the frontal bone, the parietal bone, the I'm going to make sure I'm saying all this right. What are the, I think, four bones? The four bones of the, I think, sphenoid as well, and temporal. It says frontal bone, parietal bone, temporal bone, and sphenoid bone. Yes. So if you have a damage in that pterion region, it's going to be an issue of, as they say, of the middle meningeal artery. And be aware, by the way, as well, what does that imply? What region of the brain will that cause problems for? Look that up as well. As far as I'm concerned, it's basically just the lateral parts of the cerebrum, because the anterior cerebellar is going to cover like kind of like the anterior part of like kind of like the anterior part of the inner surface, and some of the anterior surface, but mainly the inner part of the anterior inner part of the hemispheres. The PCA covers all the back of the brain, of course, PCA posterior, and that also is going to cover more of the internal stuff. But the MCA is almost completely just like the lateral sides of the brain. But whatever. We're talking about middle meningeal artery in this case, which is a little. Well, now I'm confusing things. Middle meningeal artery is a little bit different. What does middle meningeal artery supply? I just want to make sure that I'm confirming that I'm not totally screwing things up. It supplies the dura mater of the outer tough meningeal layer, okay, of the middle and anterior cranial fossa. It is the largest of the three arteries and supplies the meninges, providing over 2/3 of the blood supply to the cranial dura along the periosteum of the inner surface of the cranial. Okay, yeah, so it's important, but it's not what I was thinking about. I was thinking about the cerebral arteries, not the meningeal arteries. So this is a cerebral artery. MMA is a cerebral artery. And, is a meningeal artery. MMA is a meningeal artery. Now, of course, if you have an MMA injury, MMA injury causes what kind of hematoma? Because it's an artery, so it causes an epidural hematoma. So just keep that in mind. Oh, yeah, well, I just read, yeah. Wow, that's crazy, yeah. Wait a minute. What kind of hematoma does it cause? It's in the book. Is epidural hematoma? Yeah. No, subdural hematoma. Also, by the way, when they say, "Oh, it's epidural hematoma," there's other things that can cause an epidural hematoma than just the MMA injury from the pterion, but that is the most common, to be fair. Subdural hematoma. Rupture of the bridging veins, the acute traumatic high-energy impact, sudden deceleration injury, or chronic mild trauma, cerebral atrophy, increase in age, chronic alcohol overuse, shaken baby syndrome. So, not fun. It is usually, by the way, you might not even notice it. Let's say, for example, you're 80 years old, you fall down, and I've got back up, no problem. It might not present itself until like a little bit later. It takes some time before it actually presents itself. It can kill you, don't get me wrong, but it's usually not this sort of rapid, quick, onset and then like following death as a consequence of it. It's a lot longer term because it is bridging veins, not like an artery, for example. So let's keep that in mind. So now we're going to go into these other hemorrhages. Okay. Subarachnoid hemorrhage. Trauma. Rupture of the aneurysm, such as a saccular aneurysm, like a Berry aneurysm, for example, or an AVM, leading to bleeding. Intraparenchymal hemorrhage. Intraparenchymal hemorrhage. Systemic hypertension most often occurs in the putamen of the basal ganglia, thalamus, pons, and cerebellum. Amyloid angiopathy, AVM, vasculitis, neoplasm, or secondary to reperfusion injury in the ischemic stroke leading to bleeding. That's intraparenchymal. I want to go look something up briefly just to make sure I'm getting this right. So AVM hemorrhage. Okay, so it is a arteriovenous malformation. Okay. Phantom limb pain. I've heard of this before. Most commonly following amputation, leading to a reorganization of the primary somatosensory cortex, causing a sensation of pain in the limb that no longer is present. Very weird thing, because let's say, for example, you're thinking about it, like logically speaking, your brain still has a region theoretically dedicated to your arm, your leg, whatever, but the thing itself doesn't exist anymore. And so it's kind of a weird thing where you can, because remember, pain pain is a matter of perception, right? You feel pain because your mind comprehends pain. And so your mind has a nervous system that connects it to various parts of the body and allows it to feel if there's damage going on in that part of the body. But what happens if you have, that region doesn't exist anymore? Even the region in the brain still exists, and so it's still possible for you to feel pain because the brain region that's dedicated to comprehending pain from that region still exists. If you had, let's give the opposite example. Let's say, for example, I had part of my brain missing. Let's say the part of the brain that is used exclusively, this is not exactly how it works, but let's say you had a part of the brain exclusively for feeling pain in your left arm. If you had that part of the brain damaged, it's missing, let's say, for example, lesions, but the arm itself is still there, and you have damage to your left arm, you might have a reflex to it, but you won't actually feel pain from it because the thing that actually gives you pain is the brain. It's not the actual limb. The limb does not cause pain. It's the brain that causes pain. Now, the limb gives you a signal saying, hey, something's going wrong. Sure. But the brain is what actually allows you to have perception. Okay? Diffuse axonal injury. Traumatic shearing of white matter tracts during rapid acceleration and or deceleration of the brain. That is to say, motor vehicle accident. Multiple punctate hemorrhages involving white matter tracts leading to a neurologic injury, often causing coma or persistent vegetative state. Not fun stuff. Conduction aphasia. Damage to the arcuate fasciculus. Global aphasia. Damage to both the Broca and Wernicke's areas. So just keep that in mind. A global aphasia is when they're both knocked out. If it's conduction aphasia, it's an arcuate fasciculus issue, though. Heat stroke. The inability of the body to dissipate heat, let's say, example, e.g. exertion, leading to CNS dysfunction, that is to say, confusion, rhabdomyolysis, acute kidney injury, ARDS, and DIC. That's not good. So the thing with life is that you want to maintain homeostasis, and so what typically happens is that you're consuming energy constantly and converting it into heat, and because you want to maintain a certain temperature, you're constantly dissipating the heat because you're generating heat. So a lot of life on a very basic level is a system that eats up energy and dissipates heat, and therefore is generating entropy, essentially. If you cannot remove the heat, you cannot actually dissipate heat, like in the case of a heat stroke, you lose your homeostasis. That is to say, you die. So yeah, you need to avoid that, essentially. It causes confusion, rhabdomyolysis, AKI, ARDS, DIC, death, potentially. So bear that in mind. Migraines, irritation of the cranial nerve 5, meninges, or blood vessels, release of vasoactive substances like neuropeptides such as substance P, calcitonin, and gene-related peptide. And they don't really explain that very well, but basically what happens is that the afferent part of the cranial nerve 5, trigeminal nerve, releases vasoactive substances, like substance P and so forth, and they cause vasodilation. This actually stretches causes stretching in the area and compression, and as a consequence, it causes pain. So basically, it's vasoactive substances leading to protein extravasation and vasodilation, leading to stretching and mechanical stress, leading to pain. Parkinson's disease, loss of dopaminergic neurons of substantia nigra pars compacta. True. So you will have a very low dopamine because that area is damaged of part of the pars compacta, the substantia nigra, and you also actually have as well, despite having a low dopamine, you also have a high acetylcholine, and so you also have this sort of cogwheel rigidity as a consequence of that as well, in addition to the dopamine deficiency. Huntington's disease, trinucleotide, CAG, repeat expansion, and Huntington HTT gene on chromosome 4, leading to toxic gain of function, leading to atrophy of caudate and putamen with ex vacuo ventriculomegaly, increase in dopamine, decrease in GABA, decrease in acetylcholine, leading to neuronal death by glutamate excitotoxicity and NMDA receptor binding. So bear in mind, glutamate toxicity is a big factor in Huntington's disease. Alzheimer's disease. Widespread cortical atrophy, narrowing of the gyri, and widening of the sulci. Senile plaques in gray matter composed of beta amyloid core, neurofibrillary tangles composed of intracellular and hyperphosphorylated tau proteins, Hirano bodies. Frontotemporal dementia, or Pick's disease. Frontotemporal dementia, lobe degeneration, decrease in executive function, and behavioral inhibition. So, this is a big issue too when you're talking about clinical presentations, because it's all about clinical stuff on a lot of these exams. It's very clinically oriented. You have to ask yourself, okay, how can I distinguish between, Pick's disease, which again is a frontotemporal dementia, versus Alzheimer's disease, which is a cortical atrophy? Well, Pick's disease is going to be more, it might be if younger people to some degree, even though that's not exactly correct, but it is a little bit more. Alzheimer's is very typically old people who are older. But Pick's disease, or frontotemporal dementia, is going to have a lot of behavioral changes earlier on that are not characteristic of Alzheimer's disease. Alzheimer's disease does cause behavioral changes, but that's usually later on in the disease compared to Pick's disease. Vascular dementia. Vascular dementia, multiple arterial infarcts and or chronic ischemia. HIV-associated dementia, secondary to diffuse gray matter and subcortical atrophy and advanced HIV infection. Idiopathic intracranial hypertension. Increased ICP associated with dural venous sinus stenosis, impaired optic nerve axoplasmic flow, and papilledema. Communicating hydrocephalus. Decrease in CSF absorption by arachnoid granulations, leading to an increase in ICP, papilledema, and herniation. So that's just an important thing, is that in the case of communicating hydrocephalus, it's not an issue of, I have the third ventricle or the foramen Monro or whatever is obstructed. It's not that. It's that you literally are not absorbing it quick enough. That's the issue of communicating hydrocephalus. Normal pressure hydrocephalus. Idiopathic CSF pressure elevated only episodically, no increase in subarachnoid space volume. Expansion of ventricles distorts the fibers of the corona radiata. Wobbly, wacky, wet triad. Now, basically the idea is this. I checked the intracranial pressure and actually it's normal, but I have hydrocephalus. How could that be? It's because it's episodic, basically, so it's not consistently like that. That's the explanation that's given typically. And so you have a wet, wobbly, and wacky presentation. Now, I want to go look that up exactly what that means, because I know it's like, okay, let's make sure that I'm getting this right. So, wet, they have urinary incontinence. Wobbly, they have gait disturbance. And wacky, they have cognitive changes like mild dementia or memory impairment. So just keep that in mind. It's not necessarily, the most, I kind of hate saying this, but like, it's not the most PC thing, but it's what we call it, basically. That's kind of the way they remember it, is wet, wobbly, and wacky. And that is for normal pressure hydrocephalus. I mean, I like to say that ironically. It's a little bit unwoke for you PC snowflake liberals, whatever. But like, it is kind of like there is a lot of cases in anything, in any field of study, I think, where you have to just remember lots of information, where you're just making up things that are not exactly the best way to phrase it, perhaps. Not the most accurate way of phrasing it, but it's kind of a very basic way of phrasing it, Non-communicating hydrocephalus. Okay, let's talk about this now. Structural blockage of CSF circulation within ventricular systems, for example, or that is to say, stenosis of the aqueductus sylvius, colloid cyst blocking foramen Monro, tumor. So what they're saying is that instead of it being an issue of you can't absorb it quickly enough or whatever, the issue at foot is that you just have an obstruction. You have a literal thing blocking off the pathway for absorption because of let's say the foramen Monro or the aqueductus sylvius or whatever is blocked. So that's a non-communicating form of hydrocephalus. Ex vacuo ventricular megaly. a decrease in brain tissue and neuronal atrophy, leading to an appearance of increased CSF on imaging. Ex vacuo ventriculomegaly, a decrease in brain tissue and neuronal atrophy, leading to an appearance of CSF on imaging. Increased CSF on imaging. Okay. Okay. So, what they're saying is that, the CSF, it looks like it's more prominent, but the reason why it's more prominent is because you just lost brain tissue, basically. That's ex vacuo ventriculomegaly. You just have large ventricles because you have a brain that's degenerating and is atrophying. Okay. Multiple sclerosis. Okay, here we go. MS. Autoimmune inflammation and demyelination of the CNS, brain, and spinal cord, leading to axonal damage. And it's also kind of has this like relapsing remitting presentation where like the white matter tracts are damaged and demyelinated, but then it kind of like relapses and remits. It comes back, goes away, comes back, goes away. It causes, like long term, it causes damage to these areas, but it's not necessarily sort of it's kind of inconsistent, you could say. I'm going to take a little bit of a break again. Okay, I'm back for now. And let's see where we have afoot. So, What we have here is osmotic demyelination syndrome. So osmotic demyelination syndrome, rapid osmotic changes, most commonly iatrogenic correction of hyponatremia, but also rapid shifts of other osmolytes like glucose, for example, causing a massive axonal demyelination in pontine white matter. It's very, very bad, very bad. But it's a consequence of like typically hyponatremia correction. Oh, I have hyponatremia. I need to go, manage that, treat that, and it causes a demyelination problem. Very serious problem. You don't want to have that happen. Acute inflammatory demyelinating polyneuropathy, subtype of Guillain-Barré syndrome. Autoimmune destruction of Schwann cells via the inflammation and demyelination of motor and sensory fibers and peripheral nerves, likely facilitated by molecular mimicry and triggered by inoculations or stress. And remember that Guillain-Barré itself, that can be induced by something like Campylobacter jejuni. So you might have a Campylobacter jejuni infection, and then later on you get Guillain-Barré. Charcot-Marie-Tooth disease, defective production of proteins involved in the structure and function of peripheral nerves or the myelin sheath. Very nonspecific, but sure. Can I look this up briefly? What are the telltale signs of Charcot-Marie-Tooth? Just to enlighten us all on that matter afoot. Let's look it up. Symptoms: high foot arches, curled toes, hammer toes, frequently tripping due to foot problem, okay, and reduced sensation of in the limbs. Okay. Gotcha. Okay, let's continue. Progressive multifocal leukoencephalopathy, or PML. Destruction of the oligodendrocytes secondary to reactivation of the latent JC virus infection causing demyelination of CNS. So, let's say, for example, JC virus typically is not particularly dangerous to people in principle because they usually have a functioning immune system. But let's say they don't. Let's say they have AIDS, for example. You can have JC virus reactivate and then cause PML. It can cause the multifocal leukoencephalopathy, which is pretty nasty demyelination of the central nervous system. Not great. So bear that in mind. Really, with AIDS, it's not necessarily the AIDS itself that kills you. It's like literally everything else that it causes that kills you because your immune system doesn't function anymore the way it should be working. So if you have this radical T cell deficiency, you're getting MAC, you're getting TB, you're getting PML. You're getting PML because of JC virus reactivation. You're getting things that can kill you that shouldn't even give you a disease normally in some cases. So keep that in mind. Sturge-Weber syndrome. Somatic mosaicism of an activating mutation in one copy of the GNAQ gene. Congenital anomaly of the neural crest derivatives leading to capillary vascular malformation, ipsilateral leptomeningeoma with calcifications, and episcleral hemangioma. Okay. Somatic mosaicism, though, of an activating gene of GNAQ. Okay. Sturge-Weber syndrome. Pituitary adenoma. Again, listen, I'm looking at the PDF thing again. I'm really not looking at that PDF because it's completely different. Well, I wouldn't say it's completely different, just differently organized. Well, it probably is kind of different, to be fair. There's probably a lot of overlap, but it's just not organized the same way. Plus, there's probably some other stuff in here that's different. Honestly, I would use whatever you have because they're going to be probably valuable regardless, but I prefer to read the most recent material. Pituitary adenoma. Hyperplasia of only one type of endocrine cells found in pituitary, most commonly from prolactin-producing lactotrophs. Let me read that again. Pituitary adenoma, hyperplasia of only one type of endocrine cells found in pituitary, most commonly from the prolactin-producing lactotrophs. So just, it's usually prolactin excess, but not necessarily. Because remember, they're going to be monoclonal. And so you're only going to have one kind of cell that's being overactive while everything else is being neglected. Spinal muscular atrophy. Spinal muscular atrophy. Congenital degeneration of anterior horns due to the SMN1 mutation, defective SNRNP assembly, leading to a lower motor neuron apoptosis. ALS, or amyotrophic lateral sclerosis. Combined upper motor neuron and lower motor neuron degeneration, familial form associated with SOD1 mutation. So that's ALS. That's the thing that Stephen Hawking had. And it basically is both UMN and LMN, which basically means that the anterior horn is being attacked, right? The anterior horn is going to cause the LMN effects, but also the corticospinal tract, which is the white matter tract that controls movement, is going to cause those upper motor neuron effects as well. Both of those things are going to be a problem in the case of ALS. Tabes dorsalis. Degeneration or demyelination of the dorsal columns and the roots in the tertiary syphilis, leading to progressive sensory ataxia, impaired proprioception, and poor coordination. So, tabes dorsalis is a tertiary syphilis consequence. Tabes dorsalis is a consequence of tertiary syphilis leading to a problem with the posterior column. Now, the posterior column is controlling or is looking for proprioception and fine touch. So if that's dysfunctional, well, then you're going to have maybe like a little bit of issues with those two things, fine touch and proprioception. But it can cause ataxia because, again, you have limited proprioception, essentially. Poliomyelitis. Poliovirus infection spreads from the lymphoid tissue of the oropharynx to small intestine and then to the CNS via the bloodstream. Cell destruction in the anterior horn of the spinal cord, which causes a lower motor neuron death, basically. So the anterior horns are messed up, and now you have a lower motor neuron problem where you have, motor impairment, right? Remember the iron lung and all that kind of stuff? You have motor impairment because of polio. Friedreich ataxia. Trinucleotide repeat, GAA, on chromosome 9 in frataxin gene, iron-binding protein, leading to impaired mitochondrial function, degeneration of lateral corticospinal tract, spinocerebellar tract, dorsal columns, and dorsal root ganglia. That sounds like a mouthful. Ooh. So the frataxin gene for Friedreich ataxia leading to issues in the corticospinal tract, spinocerebellar tract, dorsal column. So that's literally all three white matter tracts, if I'm not mistaken. So that's so the motor tract, the pain and temperature tract, and the proprioception and fine touch tract. So literally all the white matter tracts, and the dorsal root ganglia, which is the sensory stuff, I believe. So everything is knocked out besides, I guess, the anterior horn, it looks like. It sounds like everything's mentioned besides that. So that sounds pretty nasty. So you don't want to get that. Noise-induced hearing loss. Damage to the stereociliated cells in organ of Corti, leading to a loss of high-frequency hearing first. So you lose the high-frequency stuff first. Again, it's the stereociliated cells in the organ of Corti for noise-induced hearing loss. Now, what about presbycusis? Now, I'm going to play a little bit of game with you. Presby refers to like an elder, right? Like presbyter, like a Presbyterian refers to the presbyter as the elder. So presbycusis is aging-related progressive bilateral or symmetric sensorineural hearing loss, often of higher frequencies due to destruction of the hair cells at the cochlear base. Aging-related progressive bilateral symmetric, blah, 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 due to destruction of hair cells at the cochlear base. Okay. So that's an aging-related hearing loss. So when it's aging-related, it's going to be bilateral, right? And it's going to be a sensorineural from the hair cells being lost at the cochlear base. Compare that to the noise-related hearing loss, which is more of a stereociliated cells at the organ of Corti. So noise-induced, organ of Corti, stereociliated cells. Age-related loss, it's hair cells at the cochlear base. A little bit different. But they're both high frequencies are what usually is the bigger issue. Cholesteatoma. Cholesteatoma, abnormal growth of keratinized squamous epithelium in middle ear, primarily primary from tympanic membrane retraction pocket, secondary from tympanic membrane perforation. So cholesteatoma, abnormal growth of keratinized squamous epithelium in the middle ear, primary from tympanic membrane retraction pocket, and secondary from just a actual perforation of the tympanic membrane. But it's a keratinization, basically, of the area. Meniere's disease, that's for a little bit of French for you. Increase in endolymph in the inner ear, leading to vertigo, sensorineural hearing loss, tinnitus, and ear fullness. So you have this endolymph is building up in the inner ear. So you have all these sorts of issues: hearing loss, vertigo, tinnitus, and he obviously is full because it has endolymph in it. And sensorineural in nature. Sensorineural, not mechanical or whatever. It's not. It is sensorineural in nature. That's the problem afoot. Now, hyperopia, not hyperborea, hyperopia. Eyes too short for refractive power of cornea and lens. Light focused behind the retina. Myopia. Eyes too long for refractive power of cornea and lens. Light focused in front of the retina. So just for reference, hyperopia, eye too short for a refractive power lens, and the light is focused behind the retina. So hyperopia is too short behind the retina. Myopia, eye is too long for refractive cornea and lens, light focused in front of retina. So again, hyperopia, light too short behind the lens. Myopia, light is too long, it's in front of the lens. The light is too, okay. Hyperopia, eye is too short, light is focused behind retina. Myopia, light is too long, it's focused in front of the retina. Okay? So myopia is long, hyperopia is actually, funnily enough, short. So, astigmatism, irregular or asymmetric curvature of the cornea or lens, different refractive power at different axes. Oh, that's weird. So astigmatism is like it's not even consistent. It's not even like this area has this refractive power here. No. It's kind of all over the place. So that doesn't sound particularly great. Now we're on to presbyopia. Again, remember presby referring to elder. Presbyopia, so it's like old eyes. Presbyopia, age-related impaired accommodation, likely primarily due to a decrease in lens elasticity. So basically, I'll try to give you a little bit of a rundown on the mechanism of that. Your body, in order to focus on things from different distances, it has to actually... It normally has these fibers, I think it's zonual fibers, that stretch out the lens. And so if you're looking at something from closely to you, let's say it's from a distance. When you have something from a distance, the fibers are normally stretching out the lens. However, if something is close to you, what you have to do is have the muscles actually are going to inhibit those zonual fibers, and that'll allow them to relax, or allow the lens to not be stretched out, and allows it, if it's elastic enough, to return to a less stretched out state, essentially. And that'll allow you to see things from a closer distance. So let's say, for example, you're reading a book. The muscles are going to be working on the zonual fibers, preventing them from stretching out the lens, and the lens is able to retract because it's elastic, and be more, let's say, a little bit more scrunched up, you could say, and allow you to see things from a closer perspective, like reading a book or something like that, or reading a menu. And when you get older, it no longer returns to its original state. It's just permanently stretched out. And so you can't really see very clearly when reading a book or reading a menu. That's why when you're old, they use glasses to read, or they use glasses to read something like a menu, or they go have their menu like it's like all the way, like, a whole few feet away from them, because it's difficult for them to see up close anymore because the lenses are permanently stretched out. And that's what presbyopia is all about. It's basically your lens is permanently stretched out at that point, so you can't see things close to you typically without glasses. Glaucoma, optic neuropathy, progressive vision loss, peripheral to central, usually with increased intraocular pressure. Let's go into the specifics of that. Open-angle glaucoma, associated with an increase in resistance to aqueous humor drainage through trabecular meshwork. True. Angle closure glaucoma, or I would phrase it as closed-angle glaucoma, but whatever. Anterior chamber angle narrowed or closed, associated with anatomic abnormalities, for example, anteriorly displaced lens resting against the central iris, leading to a decrease in aqueous flow through the pupil, leading to an increase in pressure in the posterior chamber, and leading to a peripheral iris pushes against the cornea, causing a drainage pathway obstructed by the iris. So basically, closed-angle glaucoma, as an analogy, it's kind of like the non-communicating hydrocephalus. It's basically obstructed from being able to leave, and so you build up all this pressure and causes the glaucoma. It's a little bit different from open angle, where there is an increased resistance to drainage, sure, but it's not literally being prevented from leaving the eye. I feel like a physical obstruction. That's more of a trabecular meshwork issue in the case of open angle. And I think, let me look at the muscarinic stuff. I think when you have muscarinics, let me make sure I'm saying this correctly. I want to confirm this because I think it's important. You can treat closed ankle glaucoma with certain kinds of drugs. So, for example, here we go. So you can treat, for example, closed ankle glaucoma with carbachol and with pilocarpine. And the reason why is because it's going to try to relax. Yeah, I think it's going to try to, it says here, bronchoconstriction, secretion, outflow of aqueous humor by contracting ciliary body. So that's just going to kind of help, if you have a muscarinic agonist, kind of help with that closed angle glaucoma. Now, diabetic retinopathy. Chronic hyperglycemia leads to an increase in permeability and occlusion of the retinal vessels, causing microaneurysms, hemorrhages, which are non-proliferative, retinal neovascularization due to chronic hypoxia, which is proliferative. So you get hypoxia, hemorrhages, retinal neovascularization. It's not good. It's not good. And that's because of the hyperglycemia, basically. Hypertensive retinopathy. Chronic hypertension leads to spasm, sclerosis, and fibrinoid necrosis of the retinal vessels. Very true. Retinal artery occlusion. Central or branch retinal artery blockage due to embolism, carotid artery atherosclerosis, rather than cardiogenic. Typically, it's more the retinal artery atherosclerosis. Less commonly due to giant cell arteritis. So yeah, I mean, it could be like this is a giant cell that blocks it. That's possible. But more commonly, it's because of it's more commonly due to some sort of embolism, typically, like a carotid artery atherosclerosis, cardiogenic origin maybe, but it's more commonly that kind of stuff. Retinal vein occlusion. Okay, this is interesting. A central occlusion due to a primary thrombosis, branch occlusion due to a secondary thrombosis at the arteriovenous crossing. Retinal detachment. Here we go. Neurosensory retina separates from the underlying retinal pigment epithelium, leading to a choroidal blood supply loss, leading to hypoxia and degeneration of the photoreceptors due to retinal tears, rhegmatogenous or tractional or exudative fluid accumulation or non-rhegmatogenous. So it's basically just detaching from the base, and therefore it can't get its blood supply, and therefore you just don't have functioning photoreceptors because they can't be supplied properly. And so that's basically what's going on in that situation for detachment. It's detaching from the underlying retinal pigment epithelium. Retinitis pigmentosa. Progressive degeneration of photoreceptors in retinal pigment epithelium. Papilledema. Increase in intracranial pressure, secondary to mass effect, typically. Leading to impaired axoplasmic flow in optic nerve, leading to optic disc swelling, usually bilateral. Relative afferent pupillary defect, which is also called Marcus gun pupil. That's RAPD or Marcus gun pupil. Unilateral or asymmetric lesions of afferent limb of pupillary reflex. That is to say, retina or optic nerve. Retina, optic nerve. Okay. So let me read it again. Unilateral or asymmetric lesions of afferent of pupillary reflex. So that's basically the sensory portion of it. Now, I want to make sure I'm not confusing this with something else. This is Marcus Gunn. Marcus Gunn pupil, also called what? It's also called, RAPD. Isn't there like another name for it? There's another kind of pupil named by a different, I think Argo Robertson. Pupil. Yeah. Argo Robertson is the prostitute's pupil, but Marcus Gunn, who's a different Scottish person, both of them are Scots. Marcus Gunn pupil is the relative afferent pupillary defect, and that is a sensory problem going on. So remember, RAPD or Marcus Gunn, that is a sensory problem afoot. Okay. Now Horner syndrome. Let's talk about Horner syndrome for a moment. I mentioned it briefly before, but Horner syndrome is lesions along the sympathetic chain. First neuron, pontine hemorrhage, lateral medullary syndrome, spinal cord lesion above the T1 like Brown-Séquard syndrome, or late-stage syringomyelia. Second neuron, stellate ganglion, compression of the Pancoast tumor. Third neuron, carotid dissection. I mean, the best way I would phrase it like this is that, you're going to have sympathetic innervation from the thoracic region, like T1 basically, going in through the neck into the face. And so that's how you get your sympathetic stimulation into the face, from that thoracic region. Now, if you have nerve damage, let's say from the lateral horn, right? If you have nerve damage somewhere across that nerve going from that thoracic region all the way to the head, if there's nerve damage somewhere, you can cause a Horner syndrome where you would have, let me just list out the actual symptoms. Horner syndrome symptoms. You would have things like a drooping eyelid is the most common one I think of. Ptosis, drooping eyelid. Meiosis, the pupil is constricted, right? Anhidrosis, you have decreased sweating. That's not as obvious typically, like, decreased sweating. Like, typically they're not sweating all that much. And you also have, that's really the three things. You think about ptosis, drooping eyelid, constricted pupil, meiosis, and then you also have decreased sweating. There's some other stuff too, but those are the three major things people talk about typically. And that is a sympathetic problem with the sympathetic system, if that's some sort of damage to that. Cavernous sinus syndrome. Secondary to pituitary tumor mass effect, carotid cavernous fistula, or cavernous sinus thrombosis related to the infection spreads due to lack of valves in dural sinus. Yeah, so basically cavernous sinus syndrome is like some sort of mass is in that cavernous sinus and it's compressing nerves in that area. What nerves are affected by cavernous sinus syndrome? I don't really like the description for some of these things. They say, oh, well, it's caused by this. Okay, but what does it cause? So cranial nerves, 3, oculomotor nerve, 4, trochlear nerve, 6, abducens nerve, and then V1 and V2 branches of trigeminal nerve. So basically it's 3, 4, 5, V1 and V2, and then 6. So 3, 4, 5, 6. But really only V1 and V2, not V3, but V1 and V2 potentially. So 3, 4, sum of 5, V1, V2, and then 6. So just keep that in mind, by the way. That's all cavernous sinus stuff that can be compressed as a consequence of cavernous sinus syndrome. They mentioned, oh, how do you get it? Okay, sure, but we need to know what it causes as well. Delirium, usually secondary to illness, let's say, for example, a CNS disease, an infection, trauma, substance use, metabolic electrolyte imbalance, hemorrhage, urinary or fecal retention, or medication like an anticholinergic. So a lot of different things can cause delirium. Schizophrenia, altered dopaminergic activity, increased serotonergic activity, decreased dendritic branching. So the dopamine is altered, serotonin is high, you have low dendritic branching. Now we're talking about kidneys now. A distal renal tubular acidosis, RTA type 1. Inability of the alpha intercalated cells to secrete hydrogen ions, no new bicarbs generated, causing metabolic acidosis. So you can't, inability of the alpha intercalated cells to secrete hydrogen. Okay. So you can't absorb bicarbs so you get metabolic acidosis. Or it says, well, you can't generate new bicarbs so you get metabolic acidosis. Okay. That's RTA1, type 1. Proximal RTA, which is RTA type 2. And that's just distal renal tubular acidosis, by the way. It's distal. Now, which implies, what is that, like CD or something? I'll look into that a little bit. Okay. Proximal RTA type 2. Defective PCT bicarb reabsorption leading to an increase in urinary excretion of bicarb, leading to metabolic acidosis. That one's a little bit more obvious to me. So RTA type 2, which is proximal RTA. What's happening here is that at the PCT, proximal convoluted tubule, typically via carbonic anhydrase, you're converting bicarb. Bicarb plus hydrogen ions combine to make a carbonic acid, and that can be broken down in the water and CO2 via carbonic anhydrase. And that water and CO2 can be reabsorbed, and then via carbonic anhydrase can be converted back into bicarb and hydrogen ions, or back into carbonic acid, which then can be converted to bicarb and hydrogen ions in the inside the cells of the body. And so that can be a way for you to constantly absorb more and more bicarb at the PCT. Now, in proximal RTA, or RTA type 2, you cannot absorb the bicarb effectively in that process for some reason. And so as a consequence, you get a metabolic acidosis because you cannot reabsorb the bicarb there. So, and then remember the type 1, RTA type 1 is going to be distal. RTA type 2 is the PCT, the proximal convoluted tubule. Next one, hyperkalemic RTA, or RTA type 4. Off the top of my head, I'm going to guess, because it says it's hyperkalemic, probably has something to do with the CD, the collecting duct. Yeah, let me read it. Hypoaldosteronism, or aldosterone resistance, causes an increase in potassium and a decrease in ammonia synthesis in the PCT, leading to a ammonium excretion, a decrease in ammonia excretion, and a metabolic acidosis. I'm a little bit surprised by that because aldosterone doesn't really have a meaningful effect in the PCT as an effect in the collecting duct. And the potassium also is really a collecting duct thing. And all that sounds like very collecting duct. So I don't know if the book's correct about that. Where does RTA type 4 happen? In the nephron. It says type 4 renal tubular acidosis or hyperkalemic RTA primarily occurs in the distal nephron, specifically within the cortical collecting tubule or collecting duct. So I'm more correct in the book. The book, frankly, saying, oh, it's in the PCT. No, it's not. Well, I mean, it says, ammonia NH3 synthesis in the PCT is decreased. Sure, I mean, I'm not going to say that doesn't happen per se, but we have to be aware of the fact that RTA type 4, because of hypoaldosteronism, and therefore hyperkalemia, right, is a collecting duct problem. So remember, type 1 is a DCT issue. Type 2 is a PCT issue, proximal convoluted tubule. And then the type 4 is a aldosterone issue. It is a collecting duct issue. So just bear that in mind. Low key, I'm probably going to skip a lot of the formulas and stuff for this reading. The equations and the I'm just looking for it in advance because I know I have to read through a lot of this stuff. It's probably going to be this video is probably going to be my longest video, to be honest with you, because this is going to be longer than my other section on the renal section, because this is just like a comprehensive thing, or it's an overview, I should say. So I will probably not read the equations, or if I do, I don't know. Honestly, if I were you, I would just read the book for an equation. I would not focus on the equations necessarily for audio purposes, I guess you could say. But everything else, though, I mean, I could read a lot of this other stuff. I'm going to take a little bit of a break again. Okay. Okay. Well, let us proceed. I like talking, but I don't like talking for hours and hours on end. I can tell you that for sure. I need to work on that, perhaps. Nephritic syndrome. Nephritic syndrome, glomerular inflammation leading to a glomerular basement membrane damage, causes dysmorphic RBCs in the urine, hematuria, decrease in GFR. Oh. Let me go plug this in. There we go. As I was saying, nephritic syndrome, glomerular inflammation causing a GBM damage, causing dysmorphic RBCs in the urine and hematuria, decrease in GFR leading to oliguria, azotemia, and an increase in renin release. Nephrotic syndrome is a podocyte damage leading to impaired charge barrier, leading to proteinuria, hypoalbuminemia leading to increase in hepatic lipogenesis, causing hypercholesterolemia, antithrombin loss leading to hypercoagulability, and IgG loss leading to infections. So, nephrotic syndrome, the important thing for nephrotic syndrome to be aware of is that you just are losing a lot of protein. You can lose protein in nephritic syndrome, sure, but you're losing a lot of protein in nephrotic syndrome, like more than 3.5. Is it grams? I want to make sure that I'm not getting that incorrect, but nephrotic syndrome, 3.5 grams per 24 hours in adults. That's what I was looking for. Okay. So there's a lot more protein loss. There's also this sort of fatty thing going when the liver says, oh, we need to start making, start releasing lipids or whatever going on in nephrotic syndrome. So it's a little bit different in terms of presentation. So let's be aware of that. Nephrotic syndrome, severe glomerular basement membrane damage leading to RBCs lost in urine plus impaired charge barrier leading to hematuria and proteinuria. So isn't that fun? You have a little bit of both. Best of both worlds, you might say, But you can't make up your mind. So you choose a little bit. It's like Neapolitan, Neapolitan ice cream. You just want to have a little bit of nephritic syndrome and nephrotic syndrome at the same time. A little bit of hematuria and a little bit of protein in your urine, right? So that's how that works. Infection-related glomerulonephritis. So that'd be like a PSGN. That'd be like a post-streptococcal glomerulonephritis. Is a good example of that. So infection-related glomerulonephritis, type 3 hypersensitivity reaction with consumptive hypocomplementemia, yeah. So that would be like, to my knowledge, that'd be something like PSGN. So let's say, for example, I got a strep pyogenes infection. 2 weeks later, I have this type 3 reaction of glomerulonephritis. It causes it's related to hypertension, stuff like that. Pretty nasty stuff. That is an example of infection-related glomerulonephritis. Alport syndrome, type 4 collagen mutation, X-linked dominant, irregular thickening, and splitting of the GBM, causing a nephritic syndrome. That's Alport syndrome. Stress incontinence, outlet incomplete, urethral hypermobility / intrinsic sphincter deficiency, leading to a leak with increased intra-abdominal pressure. That's to say, like sneezing or lifting. So, let me see. Let me read this correctly. I mean, really, for stress incontinence, it's like, you see this in women, right? Or women who have given birth. Let me phrase that specifically like that. Where, yeah, they sneeze or they have some sort of thing where they have a lot of abdominal pressure and it causes them to accidentally experience incontinence, essentially, as a consequence of that. Overflow incontinence, a little bit different. Incomplete emptying, detrusor underactivity, or outlet obstruction leading to a leak with overfilling, essentially. So you're just not urinating. You're just not urinating when you should. You're experiencing incomplete emptying, and so you just have this buildup or overflow that leads to incontinence later down the line because you just don't have any room for it anymore. So, pre-renal azotemia. Let's talk about it. Decrease in the renal blood flow, leading to a decrease in GFR, leading to an increase in reabsorption of the sodium and water and urea. Okay. So pre-renal, low renal blood flow. So there you have low GFR, so you have a lot of more reabsorption, so you have azotemia. Intrinsic renal failure. Let's talk about it. Intrinsic patchy necrosis, leading to debris obstructing tubules and fluid backflow, causing a decrease in GFR. What about post-renal azotemia? What's causing that? Well, outflow obstruction, bilateral. So basically, there's really three types. There's the pre-renal, intrarenal, and post-renal. If it's post-renal, it's something that's obstructing it, like a kidney stone, or maybe like they have BPH or something, or maybe they have a prostate cancer, maybe something like that's obstructing the flow. It might be, again, intrarenal. We're talking about something wrong going on in the kidney itself, like a patchy necrosis. There's debris obstructing the tubules, something causing a fluid backflow, whatever. If it's pre-renal, it typically is going to be a loss of blood flow to the kidneys. So that's kind of the way those things work. If it's pre-renal, it's usually a blood flow to the kidney problem. If it's post-renal, it's usually some sort of obstruction. If it's intrarenal, it's something wrong inside the kidneys themselves. So, adnexal torsion. Twisting of the ovary or fallopian tube around the infundibulopelvic ligament and ovarian ligament, leading to a venous or lymphatic blockage, causing arterial inflow continues, leading to edema, blockade of arterial inflow, and necrosis or hemorrhage. Okay. So basically, the way we want to think of this as this: when you have an adnexal torsion, it doesn't just mean like ovarian torsion. They just mean ovarian torsion or fallopian tube torsion. Pretty bad stuff, but this is what they're referring to in that context. Preeclampsia, not good, not good. Abnormal placental spiral arteries leading to endothelial dysfunction, vasoconstriction, ischemia, and new onset hypertension with proteinuria. Let me read that again. Abnormal placental spiral arteries leading to endothelial dysfunction, vasoconstriction, ischemia, and new onset hypertension with proteinuria. So if you have that, that could be an emergency situation if you actually have eclampsia. Now, this is preeclampsia, of course. But that's a new onset hypertension and proteinuria. Supine hypotensive syndrome. Supine position, gravid uterus compresses the abdominal aorta and IVC, leading to a decrease in placental perfusion and causing a decrease in venous return. So basically just compressing the return of blood flow and causes a hypotension situation. Polycystic ovary syndrome, so PCOS. I think a lot of people have that. Well, I don't have that because I don't have ovaries, but there's a lot many women who have that. PCOS. Hyperinsulinemia and or insulin resistance, leading to an altered hypothalamic feedback response, leading to increase in LH to FSH ratio. I'd assume is what they're talking about, increased LH to FSH ratio. Increase in androgens, increase in rate of the follicular maturation, unruptured follicles or cysts, and anovulation. So yeah, it's a lot of issues with it, a lot of hormonal problems associated with PCOS. It can cause obesity. It can be associated with anovulation, fertility issues, of course. I think potentially increased risk of miscarriage and stuff like that. I think it's associated with hirsutism even potentially. So there's a lot of more of these androgenic effects you can see with PCOS. Functional hypothalamic amenorrhea. Severe caloric restriction causing increased energy expenditure and or stress leading to altered pulsatile gonadotropin-releasing hormone secretion, causing a decrease in LH, FSH, and estrogen. Yeah, so basically you just don't have normal hormones because you have some sort of stress problem or an energy problem, or you just don't have calories, basically. So you will see that if you have someone who has, let's say, anorexia, for example, they might have a situation where they just aren't experiencing periods. They might have amenorrhea because they just are not consuming enough calories. So, varicocele. Increase in venous pressure, dilated veins in the pampiniform plexus, enlarged scrotum, which is a bag of worms presentation. So you will have, if you're a doctor, you would feel it, or if you have the patient, you would feel the scrotum, and it feels like there's a bag of worms in there. and that's because of this dilation of that, because it cannot return back into the body effectively, and that might be a case of some sort of thing is compressing them or something like that, typically. Now, methemoglobin. Increase in oxidized hemoglobin, iron, 3+, secondary to dapsone, local anesthetics, nitrates, leading to a decrease in O2 binding, but increase in cyanide affinity, tissue hypoxia. When I think about methemoglobin, I'm usually thinking about nitrate toxicity, for example. I have way too much nitric oxide that can cause methemoglobinemia. Apparently, it can also be caused by dapsone and local anesthetics in addition to the nitrites. But that causes tissue hypoxia at the end of the day. Sarcoidosis-associated hypercalcemia. Non-caseating granulomas leading to an increase in macrophage activity, leading to an increase in 1-alpha hydroxylase activity in macrophages, leading to vitamin D activation and increase in calcium. So basically, the non-caseating granulomas, this sort of long-running process, leads to increased calcium absorption, for what it's worth. ARDS. If I'm not mistaken, that's acute respiratory distress syndrome. Let's talk about it. Alveolar injury leading to inflammation, leading to capillary endothelial damage and an increase in vessel permeability, causing leakage of protein-rich fluid into the alveoli, leading to intra-alveolar hyaline membranes and non-cardiogenic pulmonary edema, causing a decrease in compliance of the V and VQ mismatch, not good, leading hypoxic vasoconstriction, and an increase in pulmonary vascular resistance. So basically, I want to kind of convey this the best that I can. Basically, because of injury, you're going to have this sort of inflammation reaction, and you're going to have this protein leakage and edema and everything like that, and then your body's like, oh, this tissue here is not very good at absorbing oxygen, because it's not. It's poor at that point because it's inflamed, it's all damaged and stuff. It's not good. So it's going to say, let's constrict this area of tissue in that particular area so that more blood can go to the other areas. So it's going to try to redistribute the blood to the other areas that are theoretically more effective at taking up oxygen. Here's the problem. That works if you have a particular location in your lungs that is damaged. It does not work if everything is damaged at the same time. And so when everything is damaged at the same time, you have universal vasoconstriction of the vessels of the lungs, and that causes pulmonary hypertension, which can cause right heart failure. So it's not good in that sense. Just be aware of that. Sleep apnea. Sleep apnea, respiratory effort against airway obstructive, impaired respiratory effort due to CNS injury or toxicity, CHF, opioids, central, obesity, leading to hypoventilation, leading to increase in PaCO2 during waking hours. Usually when you talk about sleep apnea, it's usually because of they're just obese, they're like overweight, or they have some sort of other kind of like issue causing obstruction where they can't really breathe correctly when they're asleep. Usually it's because of some sort of physical obstruction, right? So because there's some sort of physical issue, because they're overweight, something like that. But it can be caused by things like congestive heart failure and opioids and stuff like that as well. And that means you just can't get enough oxygen, and that means it makes it very, very difficult for you to get sufficient oxygen at night. You might have issues with getting good sleep at night, and there's a consequence amount of drowsiness in the day, So, not fun. Okay. Next page. All this stuff is classical presentation stuff. So when I get to another section, because this is wait. Oh, no. This is new. Sorry. The page is new right now. This is classical presentations. I was working on, for the last whatever number of pages, pathophysiology of important diseases. Okay, so we were doing pathophysiology before. Now we're doing a little bit of something different. This is going to be a little bit of a guessing game for you. I'm going to describe a clinical presentation, And then you're going to have to tell me, which I can't hear you, but like you get the idea. You're going to tell me a diagnosis or disease that causes that clinical presentation. So I might say, oh, this patient has, XYZ issue. What's causing it? And then you say, oh, well, of course, it's this. Okay, whatever, that kind of thing. So let's do it. Classic presentations. And let me see if I have the equivalent in this textbook here, because I was looking through this kind of stuff, like where is this, where's the overlap? And here, wait, is this the same thing? No, it's not. This is classic lab findings. I don't care about lab findings. I care about clinical presentation. What's the patient doing when they come into the office, Oh, no. We'll get to it. We'll get to it. I wonder if this old PDF version of it is like shorter. I'm not sure. Oh, they're just missing a section, maybe. I don't know. Yeah, no. This is the same. Both of them have a classical presentation section, which is good. The problem is that this one is ordered differently. This one's ordered differently. Mine is not. Mine is not in alphabetical order. That one is in alphabetical order. Mine starts with gout. Theirs does not start with gout. Mine's all over the place. So let me just go. My order is based off of the where they occur in the book overall. So the first one is for this gout, etc. is page 35. Citus and verses. The next one starts on 47 and goes down the list like that. This is based on alphabetical order in your PDF right here that I'm showing on the screen. But I will follow my own textbook. Clinical presentation. Gout, intellectual disability, self-mutilating behavior in a boy. What is it? Lesch-Nyhan syndrome. It's like, what's this Pokemon? Like, Lesch-Nyhan syndrome. HGPRT deficiency, X-linked recessive. Citus inversus, chronic ear infections, sinusitis, bronchiectasis, infertility. What is it? Primary ciliary dyskinesia, also called Carter-Jenner syndrome. Okay. Blue sclera, multiple fractures, dental problems, conductive or mixed hearing loss, osteogenesis imperfecta, which is a type 1 collagen defect. Okay. I like my system better. I like this one better because it's a little bit more consistent, I think. A little bit better in my opinion in terms of logical thinking. So, next one. Elastic skin, joint hypermobility, bleeding tendency. Ehlers-Danlos syndrome, type 5 collagen defect, type 3 collagen defect seen in vascular subtype. Okay. So Ehlers-Danlos is a type 5 collagen problem. Elastic skin, hypermobility of joints, bleeding tendency. Arachnodactyly, lens dislocation, upward and temporal, aortic dissection, hyperflexible joints. That's Marfan syndrome. That's a defect in fibrillin 1. So remember, I always confuse the two, Ehlers-Danlos and Marfan syndrome. Marfan syndrome is a fibrillin 1 problem, and the Ehlers-Danlos is a type 5 collagen defect. Ehlers-Danlos has the elastic skin and hypermobility. The Marfan syndrome has these long limbs and lens dislocations kind of thing. But they're both they're hypermobile for joints regardless though. But I think arachnodactyly is what's characteristic of Marfan's. Let's continue. Arachnodactyly, pectus deformity, lens dislocation, downward and nasal. What is it? Homocystinuria, an autosomal recessive cystethionine synthase deficiency. So it sounds kind of similar to Marfan's. It says, arachnodactyly, just like Marfan's. Lens dislocation, just like Marfan's, but this one is actually going to be downward and nasal, while Marfan's is upward and temporal. Marfan's also has an aortic dissection problem as well. So bear that in mind. So I'm going to go with that. Ehlers-Danlos, type 5 collagen, elastic skin, Marfan's, arachnodactyly, aortic dissection, and then homocystinuria, arachnodactyly, chest deformity. Café au lait spots, unilateral. polyostotic fibrous dysplasia, precocious puberty, multiple endocrine abnormalities. Okay, it's McCune-Albright syndrome, G protein activating mutation. I was thinking about something else, but McCune-Albright for that one. It has cafe low spots, but it's unilateral though, and a polyostotic fibrous dysplasia, and precocious puberty, and multiple endocrine abnormalities. Okay, that sounds like it could be a couple different things, but but that is actually McCune-Albright in that case. It's a G sub S protein activating mutation. Okay, next one. Meconium ileus in the neonate, recurrent pulmonary infections, nasal polyps, pancreatic insufficiency, infertility or subfertility, malabsorption/vitamin deficiencies. I want to say CF? CF. Cystic fibrosis. I'm doing a little bit guessing game for myself, honestly. Cystic fibrosis, CFTR gene defect, chromosome 7, delta F508. Next one. Calf pseudohypertrophy. Muscular dystrophy, most commonly Duchenne, due to X-linked recessive frameshift mutation of the dystrophin gene. So calf pseudohypertrophy would be muscular dystrophy, usually Duchenne. Child uses arms to stand up from squat. That's kind of weird. Duchenne's muscular dystrophy, Gower sign. So that's the Gower sign from Duchenne's muscular dystrophy. Slow, progressive muscle weakness in boys. Becker muscular dystrophy, X-linked non-frame-shifted deletions in dystrophin, less severe than Duchenne's. Okay, that's Becker muscular dystrophy. Infant with cleft lip palate, microcephaly or holoprosencephaly, polydactyly, Q dysplasia. Well, that's Patall syndrome, which is trisomy 13. When we talk about chromosome abnormalities, or say trisomies, for example, usually it's going to be fairly common ones are going to be Down syndrome, which is trisomy 21. It's going to be maybe like a Turner syndrome, which is like a missing an X chromosome. It's going to be something like maybe Klinefelter's, which is like an extra X chromosome for a male. But these ones where you have like Patau is a lot less common in terms of how many people are actually showing up with it who make it actually past birth, Patau syndrome, again, that's a cleft lip, palate, microcephaly, that kind of stuff. Next one. Infant with microcephaly, rocker bottom feet, clenched hands, structural heart defect. That's Edwards syndrome. Edwards is 18. Edwards 18, you have the heart defect and the feet problems, basically, and the clenched hands. Single palmar crease, flat facies, prominent epicanthal folds, congenital heart disease, and intellectual disability. That would be Down syndrome, trisomy 21. Microcephaly, high-pitched cry, intellectual disability. Well, the high-pitched cry, that's what we call cri du chat, which means cat's cry. Cry of the cat, if you're going to be very... Cri du chat. Is it cri du chat? I don't want to speak French, so... Cry of the cat syndrome, congenital deletion of the short arm of chromosome 5. Short arm of chromosome 5 causes that high-pitched cry, intellectual disability, microcephaly. Next one, confusion, ophthalmoplegia or nystagmus, ataxia. What was it? Wernicke encephalopathy, add confabulation / memory loss, and personality changes for Korsakoff syndrome. So that's an important thing. So when you have Wernicke's encephalopathy, you're going to have some confusion, ophthalmoplegia, nystagmus, ataxia. But when you get to Korsakoff syndrome itself, that's basically beyond return. You have a real serious problem with Korsakoff syndrome. It's beyond return, and you do have a personality change at that point. But you do have confabulation, memory loss, and Wernicke's as well. Dilated cardiomyopathy, high output heart failure, edema, alcoholism, or malnutrition. Wet beriberi, thiamine B1 deficiency. So wet beriberi, which is a B1 deficiency, or thiamine deficiency, that is going to be with dilated cardiomyopathy and a high output heart failure, edema, alcoholism, or malnutrition. Okay, next one, dermatitis, dementia, diarrhea. That sounds like a B deficiency of some sort. Pellagra is B3. Yeah, pellagra. Dermatitis, dementia, diarrhea is B3 deficiency, pellagra. Burning feet syndrome, dermatitis, enteritis, alopecia. That's pantothenic acid, which is a B5 deficiency. So when you have burning feet syndrome with the alopecia and pruritus, so forth, that is a pantothenic acid or B5 deficiency. Megaloblastic anemia, subacute combined degeneration, paresthesia, and cognitive changes. That sounds like B12, right? That is called a cobalamin or B12 deficiency, causing malabsorption, caused by malabsorption, decreased intrinsic factor, or absent terminal ileum. So basically, you can't absorb B12 for some reason or another because of the ileum is lost, part of it's lost for some reason, or you have malabsorption, or you have decreased intrinsic factor, and so you have this megaloblastic anemia and subacute combined degeneration. And cognitive changes because it causes CNS problems. Swollen gums. Ooh, I'm thinking. Yeah, it is. Okay. Let me read it. Swollen gums, mucosal bleeding, poor wound healing, petechiae, corkscrew hairs, and perifollicular hemorrhages. As you can imagine, that's scurvy. That's a vitamin C deficiency, inability to hydroxylate proline or lysine for collagen synthesis, causing tea as a tea and toast diet. So you just aren't consuming vitamin C, and so as a consequence, you get all these issues. Because you need vitamin C to hydroxylate the proline and the lysine for making collagen. And you're going to really see that in the gums and in the in like hair and stuff like that, and the healing issues. Okay, I'm going to take a little tiny break again. Okay. So I'll get back into it, and I think what I'm going to do is I'm going to do classical presentations, finish that up, and then end the stream. There's a lot more content in here, of course, that you should review, but I'm not sure how much I'm going to get out of it by live streaming it necessarily. I'll probably just review that independently, as I would recommend you if you would want to review this kind of material. So let's see. Clinical presentations. Bow legs, children, bone pain, and muscle weakness. What are we thinking? Vitamin D deficiency. Rickets in children, osteomalacia in adults, causing from a decrease in sun exposure or chronic kidney disease. Hemorrhagic disease of newborns with a increase in APTT, normal bleeding time. Vitamin K deficiency. So their bleeding time is normal, but their APTT is elevated. And remember that, keep that in mind as well. If I'm not mistaken on this kind of front, I know if it comes to, I think, heparin, you use PTT for measurement, but for warfarin, which by the way is a V-core inhibitor, antagonist I should say, That is actually going to be measured by PT, so I'm not quite sure how that squares with this, but something to be aware of. Intellectual disability, musty body odor, hypopigmented skin, eczema. What are we thinking? PKU, phenylketonuria, or tetrahydrobiopterin BH4 deficiency. But PKU. And you have that kind of, they don't mention anything about the urine about it, but the PKU is going to be, is why it's called phenylketonuria, you know. But they have intellectual disability if they don't get treatment for it like very, 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 very early on, you know. Bluish black connective tissue, ear cartilage, sclera, severe arthralgias, urine turns black on prolonged exposure to air. What is this? Alkoptonuria. Interesting. Homogenetisate oxidase deficiency, acronosis. Very interesting. Infant with hypoglycemia, hepatosplenomegaly, and cardiomyopathy. Cory disease, debranching enzyme deficiency, or von Gierke's disease, glucose 6-phosphatase deficiency, more severe. Chronic exercise intolerance with myalgia, fatigue, painful cramps, and myoglobinuria. McArdle disease, skeletal muscle glycogen phosphorylase deficiency. Cherry red spot on macula. What is that caused by? Tay-Sachs disease. Tay-Sachs disease, ganglioside accumulation, no hepatosplenomegaly, Niemann-Pick disease, sphingomyelin accumulation, hepatosplenomegaly, central retinal artery occlusion. So they're saying it could be Tay-Sachs or Niemann-Pick disease, I guess. Okay. I'm just reading through these things to make sure that I understand some of this stuff. So if you have infant with hyperglycemia, hepatosplenomegaly, cardiomyopathy, there's going to be Cory disease or Gierke's disease, which is a glucose 6-phosphatase deficiency. Okay. Okay, good. Hepatosplenomegaly, pancytopenia. Ooh, okay. Osteoporosis, avascular necrosis, a femoral head. What are we thinking? Bone crisis. What are we talking about? Gaucher's disease. Glucocerebrosidase, beta glucosidase deficiency. Okay. Achilles tendon xanthoma, corneoarchus. What are we thinking? Familial hypercholesterolemia, decrease in LDL receptor signaling. Male child, recurrent infections, no mature B cells. Bruton disease, X-linked agammaglobulinemia, BTK gene deficiency. So no mature B cells, think about BTK deficiency. It's X-linked, by the way. Anaphylaxis, following blood transfusion, atrophy, airway, GI infections, or autoimmune disease. Selective IgA deficiency. So selective IgA deficiency can cause this anaphylaxis following this blood transfusion, atopy, airway, GI infections, autoimmune diseases. Fair enough. Okay. Recurrent cold, non-inflamed, abscesses, eczema, increased serum IgE, eosinophils. Hyper IgE syndrome, Job syndrome. Would it be Job syndrome or Job syndrome? Is it like Job from the Bible or Job like you have to go, apply for a job? I'm not quite sure. Job syndrome, neutrophil chemotaxis abnormality, STAT3 mutation. Okay. If you have elevated IgE with all this other stuff, it's probably hyper IgE and IgE syndrome, which is also called Job syndrome. Late separation, greater than 30 days, of umbilical cord, no pus, recurrent skin, and mucosal bacterial infections. What are you thinking with that one? Leukocyte adhesion deficiency. Yep, type 1, defective LFA1, CD18 integrin. So that is a leukocyte adhesion deficiency. Very important stuff. That's a good one. Recurrent infections and granulomas with catalase-positive organisms. What are we thinking? This should be obvious. CGD, right? Yeah, CGD, chronic granulomatous disease, defective NADPH oxidase. That means you can't make superoxide anymore from normal oxygen, so you can't make ROS on your own. And so when you have bacteria that are able to neutralize their endogenous or native what do you call it? Oh, my mind is losing its foot. When it's able to neutralize its own ROS by catalase, you can't make bleach. You just can't. Sorry, and so you're susceptible to those kinds of organisms in CGD. Fever, vomiting, diarrhea, desquamating rash after prolonged use of nasal pack or tampon. Let's read about it. Staph toxic shock syndrome. Yep, that sounds about right. So I think specifically that's TSST1, I think is the toxin that causes the one with the tampon, TSST1. But that's from staph toxin, so just be aware of that. Strawberry tongue. Okay, we're still talking staph still. Scarlet fever, sandpaper rash, Kawasaki disease, lymphadenopathy, high fever for 5 days. So when you have strawberry tongue, it could be a staph infection, like a strep. I said staph, strep. Strep pyogenes, I should say. Strep pyogenes can cause scarlet fever, which gives you the strawberry tongue, and sandpaper rash apparently. Or you could have Kawasaki disease with lymphadenopathy and high fever for 5 days. That's also something that can cause strawberry tongue. Colon cancer associated with infective endocarditis. Streptococcus galolyticus, formerly called strep bovis. Yeah, so when we think of bovis or galolyticus, we don't really think about that all that much. It's like, oh, it's like a group D strep, it's gamma hemolytic, who cares, whatever. But it is actually a cause of not only an endocarditis, but actually a type of endocarditis that leads to where is it? It leads to a colon cancer. So it's pretty serious stuff. It's a very, very weird association, but just be aware of it. Descending flaccid paralysis in newborn baby after honey ingestion. That should ring a bell to you right there. A couple different things going off to my mind. Clostridium botulinum infection, floppy baby syndrome. I would say it is floppy baby syndrome in a certain sense. I would also call Verdnig-Hoffman disease also floppy baby syndrome, which is a little bit different in terms of its origin. What is different from its origin as far as I'm aware. But yes, this is an example of a floppy baby syndrome. Is a form of it's not spastic paralysis. My mind is losing itself, I suppose. It is a flaccid paralysis with botulinum toxin. And in kids, now you can get, as an adult, you can get it, I think, from canning, like canned food. But as a child, you get it from something like honey. So that's why you have to be aware of giving infants honey, because they can run into this issue. So this is very aware of that. It's the botulinum toxin. Abdominal pain, diarrhea, leukocytosis, recent antibiotic use. What are we thinking? Clostridium difficile infection. So Clostridium difficile, that is a Clostridium species again, because Clostridium, we have difficile, which causes the diarrhea and stuff. We have perfringens, which causes gas gangrene. We have the botulinum, which causes botulism, right? We have the one tetany, which causes, tetanic paralysis, right? Which is also called spastic paralysis with tetanus toxin. So we have all those different kinds of diseases related to the Clostridium family. But Clostridium difficile is going to have that diarrhea effect, essentially. It has an A toxin and a B toxin. Just be aware of that. The grayish-white pseudomembranous pharyngitis with bull's neck appearance. What are you thinking with that one? I'm thinking diphtheria. What is it going to be? Yep, Corynebacterium diphtheria infection. That has a toxin that it messes with the elongation factor 2, and that's going to have that sort of effect on that. That's kind of the major toxin in diphtheria. So, and it does cause that gray pseudomembrane appearance as well in the bull neck and all that other kind of stuff. Those are very telltale signs. Back pain, fever, night sweats. What are we thinking? Pott's disease. Okay, fair enough. Vertebral TB. So TB, if it gets really bad, it can cause Pott's disease. It goes into the vertebra. You have fever, back pain, night sweats. I would say it's not very specific, but apparently it is for Pott's disease. Acute adrenal insufficiency. Fever. Bilateral adrenal hemorrhage. What are we thinking? Bilateral adrenal hemorrhage. That's crazy. What is it going to be? Waterhouse-Friedrichsen syndrome. Meningococcemia. So let's say, for example, I have Neisseria meningitidis. That could lead to a Waterhouse-Friedrichsen syndrome of meningococcemia, and that can cause acute adrenal insufficiency, fever, bilateral adrenal hemorrhage. It's very, very bad. You don't want to get that. Okay. Next page. I'm going to be here longer than I expected, or I hoped, I suppose, you know. Let's see. Clinical presentation. Red currant jelly sputum in patients with alcohol overuse or diabetes. What are we thinking? Klebsiella pneumonia, of course, right? That jelly presentation, that's and it's a fun thing too, because I like these telltale signs, but like, let's be honest, when you're taking the exam, they're not going to be that overt. They're not going to say, "Wow, they have a red currant jelly sputum. Well, what is that going to be?" You know, it's not going to be that simple typically, but you know, it's good to know. Fever, chills, headache, myalgia following an antibiotic treatment for syphilis. That's going to be. They're going to say Jarisch Herxheimer. I'm going to say Jarisch Herxheimer reaction. Host responds to sudden release of bacterial antigens. Well, that's the headache and myalgia caused by syphilis treatment. Large rash with bull's eye appearance, flu-like symptoms. What are we thinking? Well, erythema migrans from a Nexodes tick bite, probably like a Lyme disease, like from Borrelia burgdorferi. Borrelia bacteria, they say. Ulcerated genital lesion. Ooh. What are we thinking? Non-painful type? We're thinking syphilis, right? Canker, non-painful to canker, indurated. Primary syphilis, treponema pallidum. If it's painful, what are we thinking? That's a cancroid, right? With exudate, with cancroid, that's from Haemophilus ducreyi. So we have Haemophilus influenza, but we also have Haemophilus ducreyi. So the way I remember it is that Ducreyi is going to make you cry because it's painful. It's painful versus the non-painful canker of syphilis. Smooth, moist, painless, wart-like white lesion on the genitals. What are we thinking? Condylomata lata, which is going to be a secondary syphilis lesion. Okay. What about a pupil that accommodates but does not react to light? Well, I would call that prostitute's pupil. Again, not exactly the typical way we would want to refer to it in a polite company, perhaps, but that is prostitute's pupil. It accommodates. It doesn't react to light. That's also called Argyll-Robertson pupil, and as an example of a tertiary syphilis or neurosyphilis. Again, the way to think about it is like this. You know, when I bring my finger close to you, the eyes are going to accommodate to that normally, right? But what happens in let me think of it like this. I'm trying to think about how to think about prostitute's pupil. Basically, when I shine light into your eye, if you have prostitute's pupil, if you have Argyll-Robertson pupil, it's not going to constrict like it normally should for some reason, basically, because of the neurosyphilis. And so if you notice that, it could be an indication of that condition. It accommodates, it doesn't react to light, though. Dog or cat bite resulting in infection, cellulitis, and osteomyelitis. I'm thinking Pastorella. Yep, Pastorella multocida, cellulitis at inoculation site. Atypical walking pneumonia with X-ray looking worse than the patient. I always forget this one, but it's mycoplasma pneumonia infection. Mycoplasma pneumonia. When you hear about a walking pneumonia, and an atypical walking pneumonia, which you can treat, by the way, with fluoroquinolones, I think, if I'm not mistaken. I think. Don't quote me on that one. That's a mycoplasma pneumonia. Now, typically pneumonia is caused by something like strep pneumonia. Strep pneumonia is a very common cause of bacterial pneumonia, but the walking pneumonia or atypical pneumonia is usually caused by mycoplasma pneumonia. Bear that in mind. Rash on the palms and the soles. Coxsackie virus, A infection, Rocky Mountain spotted fever, or secondary syphilis. Bear in mind, Coxsackie virus is an A16 type. There's A, A16, and B. B, you're thinking about pleurodynea, like devil's grip on the lungs and stuff like that, on the chest. When you think about A, you're thinking typically herpangina. But A16 type, you're thinking about hand, foot, mouth disease. So if you have issues with the hands and the feet, it might very well be Coxsackie virus A16 infection. But yeah, Rocky Mountain spotted fever, maybe. Secondary syphilis, maybe. Whatever. Black eschar on the face of a patient with diabetic ketoacidosis and or neutropenia. What are we thinking? Mucor or rhizopus fungal infection. And when you think black eschar, you're thinking, oh, it must be anthrax, like a dramatic form of anthrax because you have the eschar on it, right? In this case, no. It could just be mucor, it could be rhizopus, something like that. Not good, obviously, but it's more likely to be something related to the... if you have somebody with DKA, that's more likely. Chorioretinitis, hydrocephalus, intracranial calcifications. Plus or minus blueberry muffin rash. Okay, what are we thinking with that? Congenital toxoplasmosis. Okay, sure. Congenital toxoplasmosis. Pruritus, serpiginous rash after walking barefoot. Microcytic anemia. Ooh, what's that? Hookworm with adena, right? Adena, ankylostoma species, Necator americanus. Hookworm can cause apparently microcytic anemia. That's interesting. Walking barefoot. Think about that though when you think about adena. And when I mean that, I mean ankylostoma and Necator americanus. Now, febrile child later develops red facial rash with subsequent spread to the body. Erythema infectosum, fifth disease. Slapped cheeks appearance caused by parvovirus B19. Good point. Fifth disease is the same thing as B19 virus, B19 parvovirus, basically. Parvovirus B19, which is a DNA virus that causes fifth disease or slapped cheeks disease, causes a red facial rash. So when you think about slapped cheeks, the cheeks are red, right? They're slapped. And so that's called slapped cheek disease. It's called fifth disease. It's called an infection of the B19, basically. Fever, cough, conjunctivitis, coryza, diffuse rash, Koplik spots, small irregular red spots on buccal/lingual mucosa with blue-white centers. Koplik spots are a little bit misleading because you think, oh, it's like on the body or something. You look in their body and see these spots. No, you look inside the mouth and you see the spots, Koplik spots. So, what's causing that? It's measles, rubeola virus, right? So that's a type of paramyxovirus. Systolic ejection murmur, crescendo decrescendo, pulsus parvis et tardis, syncope, angina, shortness of breath on exertion. What are we thinking? Aortic stenosis. Aortic stenosis will cause that presentation. Crescendo decrescendo appearance for aortic stenosis. Good way to phrase it. You don't want to take music theory or band in this in the medical school, but apparently that is useful for understanding how it works. Hyperdynamic pulses, wide pulse pressure, early diastolic murmur, decrescendo, head bobbing. What are we thinking? Aortic regurgitation. Now, what about a holosystolic? I'm saying holosystolic myself, but they're saying a machine-like murmur. If we have a machine-like murmur, what are we thinking? PDA is which you use to close with an indomethacin and keep up with the PGE1 and PGE2 analogs. So basically, if you have a machine-like murmur, it's probably PDA. And typically, when you have a PDA, it's obviously pathological in nature. So you want to say, oh, well, I want to go close up my pant ductus arteriosus by using indomethacin. However, there are certain situations where you need to keep it open for a certain period of time, because if you don't, because of other dysfunction in your cardiovascular system, you won't be able to get blood across the body and you will die. So you can actually keep it open for a longer period of time by using a prostaglandin analog like PGE1 or PGE2 analogs. But normally, in all cases it's pathological, but normally hypothetically you don't want to have it. So you could use indomethacin for that, for kind of hastening its closure. Chest pain on exertion. Angina, stable with moderate exertion, unstable if it has minimal exertion or at rest. So basically, the difference between stable and unstable angina is that if you have it at rest, it's unstable. If you only have it during exertion, it's stable. You don't want to have either, but, just for reference. Chest pain with ST depressions on EKG. If it's depressions, it's going to be, I believe it's subendocardial, right? Yeah, well, let me read it. Angina minus troponins or NSTEMI plus troponins. That's saying non-ST elevated myocardial infarction. So that's basically a form of acute coronary syndrome, which is a heart attack form of that. MI is a heart attack. And so that's a more radical problem compared to angina. They're both ACS issues, but STEMI in this case is going to have the troponins because it's going to have that more serious cardiac damage, while the angina will not have that. But they will both have ST depression, theoretically, if they're both subendocardial in nature, in the case of that. Chest pain, pericardial effusion or friction rub, persistent fever following MI. What are we thinking? Post-cardiac injury syndrome, autoimmune-mediated post-MI pericarditis, weeks to several months after acute episode. Distant heart sounds. Okay, distant heart sounds. Distended neck veins. Hypotension. What are we thinking? Beck triad of cardiac tamponade, I guess you could say. Not good. Very bad signs. Descended neck veins, hypotension, distant heart sounds, very bad sign. Cardiac tamponade. That's the Beck triad, by the way. Painful, raised, red-purple lesions on pads of fingers and toes. That's Osler nodes. Immune complex deposition in infective endocarditis. So when you have infective endocarditis, you can get these Osler nodes on the finger pads and on the finger pads and fingers and toes. Okay, next section, next page. I have a little bit less than 4 pages to get through, so I'll try to get through this and then end there, I think. Okay. Painless erythematous lesions on palms and soles. What are we thinking? Janeway lesions. Okay. Septic emboli, microabscesses, and infective endocarditis. So it's kind of like the Osler things we were talking about before. It's an indication of an infective endocarditis in the palms and the soles. Splinter hemorrhages and fingernails. What are we thinking with that? Interesting. Infective endocarditis. Wow, that's fun. A lot of infective endocarditis problems. Okay. Retinal hemorrhage. Retinal hemorrhage. What are we thinking? With pale centers. Retinal hemorrhage with pale centers. What are we thinking? Rough spots. What is that indicative of? What do you think? As you can imagine, it's also infective endocarditis. Telangiectasias, recurrent epistaxis. Wait a minute. Okay. Telangiectasias, recurrent epistaxis, skin discoloration, arteriovenous malformations, GI bleeding, hematuria. What are we thinking? That's a lot of stuff going on at the same time. What are we thinking? Hereditary hemorrhagic telangiectasia, also called Osler-Weber-Rendu syndrome. That's fun. What about polyuria and polydipsia? I'm drinking a lot. I'm peeing a lot. What do you think is going on? DI. Whoa. It says here primary polydipsia, diabetes mellitus type 1 or type 2, or diabetes insipidus, central or nephrogenic. So that's very non-specific. They could be DI, it could be DM, it could be even primary polydipsia. You just like to drink a lot of water for some reason. We don't know if it's a psychological thing or it's something else. No lactation postpartum, absent menstruation, cold intolerance. What are we thinking? Sheehan syndrome, severe postpartum hemorrhage leading to a pituitary infarction. Sheehan syndrome. Heat intolerance, weight loss, palpitations, fine tremor, hyperreflexia. That should be a lot of alarm bells going off for hyperthyroidism. What about the opposite? Cold intolerance, weight gain, brittle hair, depressed mood, hyporeflexia. What are we thinking? Hypothyroidism. What about this? Cutaneous/dermal edema due to deposition of mucopolysaccharides in connective tissue. This is kind of related. This is called mixed edema, caused by hypothyroidism or hyperthyroidism in the case of Graves' disease. So it's just kind of an issue related to the mucopolysaccharides in the connective tissue creating sort of edema, right? It's sort of related. It's kind of related to some of these presentations. Facial muscle spasm upon tapping. What is it? Schwastek sign in hypocalcemia. So if you have this sort of weird twitching when touching the facial muscles, you might have a hypocalcemia, and you're showing off this Schwastek sign. That's CHVOSTEK. Carpal spasm upon BP cuff inflation. So I'm kind of like inflating the blood pressure cuff here in the office, okay. And he has this carpal spasm. Like, what's going on? What's causing that? Trousseau sign. That's caused by hypocalcemia as well. So these kind of spasms that we're experiencing, those are because of hypocalcemia. In that case, again, it was Trousseau sign in that situation. Or Trousseau, whatever. TROUSSEAU sign. Rapid, deep, labored breathing, hyperventilation. Diabetic ketoacidosis, Kussmaul respirations. That is a DKA indication, yeah. Because your body is producing all this sort of acid, so you're trying to breathe off, get rid of that acid, these ketones. You're trying to get rid of this. I don't remember what exactly are they actually trying to get off. I think it's acetone. Acetone is what I'm trying to think. I think you're trying to get rid of acetone, so you're trying to breathe all that off, and so that's why you have that Kussmaul labored breathing. It's rapid too. Skin hyperpigmentation, orthostatic hypotension, fatigue, weakness, muscle aches, weight loss, GI disturbances. What are we thinking with that one? Well, it's chronic primary adrenal insufficiency called Addison's disease. Causes an increase in ACTH and MSH. And remember, with Addison's disease, the MSH is kind of a funny, interesting one because it does cause hyperpigmentation because you're producing more melanin than you typically would. So just be aware of that as well. Shock, altered mental status, vomiting, abdominal pain, a weakness, fatigue in patient on glucocorticoid therapy. What are we thinking with that one? Acute adrenal insufficiency, adrenal crisis. So this is actually one of the bigger issues with, let's say, some sort of deficiency in hormones. I mean, is the ACTH deficiency? Is it like an adrenal insufficiency? Because you just aren't, you can get like a shock-like presentation because of the glucose deficiencies. Or shock, altered mental status, vomiting, abdominal pain, weakness, fatigue, in patient glucocorticoid therapy. Yeah, I mean, it's just that you have a deficiency in ACTH, and so you can get this shock-like presentation. It's not good. Very, very dangerous, potentially. Adrenal crisis, right? What about this? Pancreatic, and I'm not sure entirely if it's all glucose. I think some other things might be going on as well. Not entirely sure. I would just look into that if I were you. Pancreatic pituitary parathyroid hormone, pancreatic pituitary parathyroid tumors. What are we thinking? MEN1, MEN1. Autosomal dominant MEN1 mutation. I think that means multiple endocrine neoplasia, if I'm not mistaken. What about this? Medullary thyroid carcinoma, parathyroid hyperplasia, and pheochromocytoma. What are we thinking with that one? Well, that's MEN2A. Autosomal dominant RET mutation. Okay. What about this one? Medullary thyroid carcinoma, pheochromocytoma, and mucosal neuromas, and marfanoid habitus. Ooh, what's going on there? Well, that's going to be MEN2B, autosomal dominant RET gene. So MEN2A, they both have pheochromocytoma, they both have thyroid carcinoma, but the MEN2A has a parathyroid hyperplasia, while MEN2B has a mucosal neuroma. So it's not exactly the same, but they're very similar to each other. And remember, MEN1 mutation is a MEN1 is a MEN1 mutation, and also has an autosomal. It also has a parathyroid hormone, sure, and a pituitary. It is pancreatic, pituitary, and parathyroid tumors. So it's all three P's for MEN1. MEN2, you got pheochromocytoma in the mix, and that kind of thing. Cutaneous flushing, diarrhea, bronchospasm, right-sided heart murmur. What are we thinking of that one? Carcinoid syndrome, urinary 5-HIAA indicates systemic dissemination. Example, i.e., for example, post-liver metastasis. Okay. Jaundice, palpable descended non-tender gallbladder. Courvoisier sign, distal obstruction of common bile duct by pancreatic head malignancy. Hematemesis, plus or minus abdominal. hematemesis plus or minus abdominal back pain. Mallory-Weiss syndrome, partial thickness, esophageal lacerations in a patient with alcohol use disorder, bulimia nervosa. Okay. Dysphagia, esophageal webs, glossitis, iron deficiency, anemia. What are we thinking with that one? Plummer-Vinson syndrome may progress to esophageal squamous cell carcinoma. If it's inflamed enough, if it's damaged enough, it might become an actual carcinoma, esophageal squamous cell carcinoma. But initially, it's Plummer-Vinson syndrome, and it has that esophageal web, basically, and they're causing dysphagia and deficiency and anemia, all that kind of stuff. And glossitis, iron deficiency, whatever. Let's continue. Enlarged, firm, left supraclavicular node. Virchow node, metastasis from the stomach malignancy. True. Well, I would phrase it like this. If you have a supraclavicular node, Virchow's node being enlarged could be, that's considered the sentinel node. So that could be a couple different things in the thoracic region in general. It's not necessarily going to be stomach. It could be something else. What about this? Hematemesis melena, upper GI bleed, peptic ulcer disease. Upper GI bleed, peptic ulcer disease. Hematemesis melena. Okay. I'm not sure exactly. Okay, sure. Okay, fine. Okay. Hematochezia. Lower GI bleed, colonic diverticulosis. So it's basically, how bright is the blood? Is the blood very dark? Right? Is it melena? It might be an upper GI bleed. Is the blood very red? Is very bright? It's probably a lower GI bleed, something like in the colon or whatever. Make sense? Like a diverticulosis in the colon. And remember, the upper would be like melena, and the lower stuff would be something like a hematochezia, where it's bright, Arthralgias, cardiac and neurological symptoms, diarrhea, Whipple disease, tropharema Whipple. So arthralgias, cardiac and neurological symptoms, diarrhea could be Whipple disease. What about severe right lower quadrant pain and palpation of left lower quadrant? That's probably going to be, Roth's. Oh, come on. Acute appendicitis. They say, severe right lower quadrant pain with palpation of left lower quadrant. That's Rothsing's sign, sure, but what does that mean? It means acute appendicitis. It means you have acute appendicitis. If you feel McBurney's point and you have a lot of pain, that's the next point they literally make. They literally say severe right lower quadrant pain with deep palpation at 1/3 from the ASAS to the umbilicus. That's called McBurney's point, right? 1/3 of the ASAS to the umbilicus. And that causes a very strong pain in that area, and that's going to be called, or going to be associated with an acute appendicitis as well. Okay, let me take a short break again. Okay. Let's continue. Hamartomatous GI polyps, hyperpigmented macules on mouth and lips, hands, and genitalia. What are we thinking? Putz-Jaeger syndrome, Autosomal dominant benign polyposis can cause bowel obstruction, increase in breast and GI cancer risk. Okay. Thousands of colon polyps, okay. Osteomas and soft tissue tumors, impacted supernumerary teeth. What are we thinking? Gardner syndrome. When you think about Gardner syndrome, think about a ton of little teeth in your mouth. Not very fun, is it? Subtype of familial adenomatous polyposis. So that's a subtype of FAP. Severe jaundice, kernicterus, neurological changes in neonate. Well, that's Crigler-Najjar syndrome, type 1, congenital unconjugated hyperbilirubinemia. Severe jaundice and kernicterus. Okay. Golden brown rings around peripheral cornea, or cornea. Wilson's disease, yeah, they say, what is that? That's called Kaiser-Fleischer rings. So they're going to call it that. Wilson's disease, Kaiser-Fleischer rings due to copper accumulation. Yes, very much so. They look kind of cool. The problem is that's a disease. It's a disease. It looks cool. Don't get me wrong. It looks kind of cool. But you don't really want to have that. Female, fat. Okay, this is the fun little thing. Female, fat, fertile, 40, fair, feeds, fasting. Okay. Which is female, fat, obese, right? Fertile, multiparity. They have a lot of kids. Multiparity. 40 or older. Fair, light-skinned. Feeds, TPN. Fasting, rapid weight loss. Okay, so that's going to be an indication of what exactly? What disease is associated with that presentation? Cholelithiasis, gallstones. Gallstones are going to associate with women who are, women who are fat, fair, 40 or over, who've had many kids, who are fasting and experiencing rapid weight loss, right? Or they're feeding, right? So there's kind of this little thing going on with that. That can cause a gallstone or associated with gallstones. Bluish line on the gingiva. What's causing that? Burton line. That's from lead poisoning. Lead poisoning causes you to have a burnt line in your gingiva. Short stature, cafe au lait spots, thumb/radial defects, increase in the incidence of tumors and leukemia, aplastic anemia, pancytopenia. That should ring a lot of bells for you. That's actually going to be Fanconi anemia. Genetic defect in DNA cross-linking repair often progresses to AML. I was actually thinking about something a little bit different from that, but that is the correct answer. It's Fanconi anemia. It's a kind of aplastic anemia. That's a key thing. It's a type of anemia, aplastic anemia, but it's going to associate with cafe au lait spots. Okay? Red, pink urine in the morning, pancytopenia, venous thrombosis. What are we thinking? Paroxysmal nocturnal hemoglobinuria. Painful blue fingers. Okay, yeah, fingers and toes. Hemolytic anemia. What are we thinking? Cold autoimmune hemolytic anemia caused by mycoplasma pneumonia, infectious mononucleosis, CLL. So it could be either mycoplasma pneumonia, it could be because of infectious mononucleosis, it could be CLL, but it's basically a kind of cold autoimmune hemolytic anemia. Petechiae, mucosal bleeding, increase in bleeding time. What are we thinking? Platelet disorders, like Landsman thrombosthenia, or Bernard-Soulier syndrome, or HUS, or TTP, or ITP, or uremic platelet dysfunction. So it could be a lot of different things. Next, low-grade fever, night sweats, weight loss. What are we thinking? B, symptoms of malignancy. This is an indication of malignancy. Low-grade fever, night sweats, weight loss. Erythematous patches, causing plaques, leading to tumors. What are we thinking? Mycosis fungoides, cutaneous T-cell lymphoma, and doesn't say anything else. Okay, fair enough. Neonate with arm in waiter's tip position followed by difficult birth. Erb's palsy. C5, C6 issue, brachial plexus injury. Superior trunk plexus injury. Now, anterior drawer sign positive, tibial glides anteriorly with respect to the femur when the knee is at 90 degrees. What are we thinking? I'm thinking anterior cruciate ligament, ACL injury. Yeah, sounds about right. Because anterior drawer would be positive if you have an ACL injury. Mosaic pattern of bone, long bone, chalk stick fractures, skull thickening, hearing loss. Skull thickening. What are we thinking with that one? Osteoitis deformans, Paget's disease of bone. Interesting. Osteoblastic and osteoclastic activity. I was thinking something different again. This is actually osteoitis deformans, which can be caused by Paget's disease of bone or an increase in osteoblastic and osteoclastic activity. Interesting. Oh, okay. Fair enough. That makes sense. That's why you have the fractures, right? I'm thinking like, the thickening, that's probably because of like some sort of growth hormone thing. No, it's not. No. If it's having fractures, it's probably not GH. It's probably Paget's disease. Swollen, hard, painful finger joints in an elderly individual, pain worse with activity. What are we thinking? Osteoarthritis. Osteophytes on the PIP, Bouchard's nodes, and DIP, Herbertin's nodes. Very important to note that it gets worse with activity. That's osteoarthritis. So if it was getting better with activity, that's probably be rheumatoid arthritis. Sudden, swollen, painful big toe, tophi. Gout / podagra. Podagra is gout of the toe, of the big toe. Hyperuricemia, caused by hyperuricemia, yes. Dry eyes, dry mouth, arthritis, parotid enlargement. Was that Sjogren's disease? Sjogren's syndrome, autoimmune destruction of the exocrine glands. Urethritis, conjunctivitis, arthritis. So you can't see, you can't pee. Is that right? Yeah, no. I'm thinking something different word. Sorry. Urethritis, conjunctivitis, arthritis. Reactive arthritis associated with HLA B27. I think that still is what I'm thinking about. I think you can get a I think it says, urethritis, conjunctivitis, arthritis. So you can't see, well, you can't pee, you can't see, you can't climb a tree. I think that is literally what I'm thinking about. You can get that from chlamydia. And that's called Reiter's syndrome, if I'm not mistaken. Mechanism of Reiter syndrome. I'm right. I'm literally correct. Reiter's syndrome is related to HLA B27 genetic marker. So I'm right. It is Candida. Not Candida, sorry. It's chlamydia. Chlamydia, right. That chlamydia can cause Reiter's syndrome. You can't see, you can't pee, you can't climb a tree. That's urethritis, conjunctivitis, and arthritis. I wish they mentioned that. I wish they mentioned it was caused by chlamydia, but whatever. It's reactive arthritis. Butterfly facial rash, arthritis, cytopenia, and fever in a female reproductive age. What are we thinking with the butterfly facial rash? Systemic lupus erythematosus, so the SLE again. Cervical lymphadenopathy, desquamating rash, coronary aneurysms, red conjunctivae in tongue, hand-foot changes, edema and erythema. Fever's been more than 5 days. What do we think? Kawasaki disease. Mucocutaneous lymph node syndrome. Treat with IVIG and aspirin. Okay. Palpable purpura on buttocks, legs, joint pain, abdominal pain, hematuria in a child. What's causing that? IgA vasculitis, which is also called a Henoch-Schönlein purpura, affects skin and kidneys. Henoch-Schönlein purpura. IgA vasculitis. Okay. Next page. Painful fingers / toes, changing color from white to blue due to red. Sorry, white to blue to red with cold or distress. Raynaud. Raynaud. Different person. Raynaud phenomenon. Vasospasm in extremities. Red to white to blue. Dark purple skin / mouth nodules in a patient with AIDS. What are we thinking with that? Kaposi sarcoma associated with HHV8. So basically HHV8, which is not usually a big problem for people, because they have a compromised immune system, they can cause these sarcomas to pop up. Not very good. Let's continue. Peritic, purple, polygonal, planar, papules, and plaques. What are we thinking? Lichen planus. So lichen planus, we're thinking, they're doing a little bit of alliteration with this. Lichen planus is related with peritic, purple, polygonal, planar, papules, and plaques. 6 Ps. Dorsiflexion of large toe with fanning of other toes upon plantar scrape. Babinski sign, which is an upper motor neuron lesion. So Babinski sign, upper motor neuron lesion, we're going to have a dorsiflexion large toe with fanning of the toes. So if you do this, you basically, the patient's sitting down or whatever, it doesn't matter, and you have the little thing, you go across the lateral part of the foot, you go in, and you say, oh, it causes, normally the toes are supposed to go down or they don't move at all. But when you have the Binsky sign, you have a upper motor neuron issue. They actually go up, which is an abnormal sign because they have an upper motor neuron lesion of some sort. Intention tremor, limb ataxia, loss of balance, fall towards the injured side. What's causing that? Cerebellar lesion, hemispheric affects voluntary movement of extremities, vermis affects the axial and proximal movement. So remember, the vermis is the axial and affects axial and proximal movement, but the hemispheric affects the voluntary movements of extremities. So hemispheric, think about the extremities. Vermis, think about the axial. And vermis is more central. So the vermis is central. It controls the central part of the body. The hemispheres are lateral. They control the lateral parts of the body, i.e. extremities. Okay? Make sense? And that's all part of the cerebellum. Hyperphagia, hypersexuality, hyperorality. What are we thinking again? We're thinking Kluver-Bucy syndrome. We were talking about that before. Bilateral amygdala lesion, HSV1, encephalitis. Resting tremor, athetosis, and chorea. Basal ganglia lesion, that e.g. Huntington disease, Parkinson disease. Yes, resting tremor, athetosis, chorea. Dysphagia, hoarseness, decreasing gag reflex, nystagmus, and ipsilateral Horner syndrome. What are we thinking with that? Wallenberg sign. Lateral medullary or Wallenberg syndrome, posterior to inferior cerebellar artery. So pica lesion, pica problem. When your posterior inferior cerebellar artery lesion, because lateral medullary syndrome, Wallenberg syndrome. Just look at the rules of 12 for that, by the way. Really do look at that. It's very important. Lucid interval after traumatic brain injury. Epidural hematoma, middle meningeal artery rupture, branch and maxillary artery, lentiform collection, not crossing suture lines. Yeah, the presentation is that it's not going to cross the suture lines, but it's going to be this sort of hematoma that forms on one side of the body, or one side of the head. And I want to look this up briefly. I want to let you know what different types of hematomas look like. So hematoma scan of the head. So let me look at these right off the top of my head. So epidural hematoma. We were talking about that before. Epidermal hematoma. It looks like a convex lens. It looks like almost like a, I don't know how to describe it, but it's convex. It is almost like a lemon shape, with one side of the lemon kind of like hugging the side of the skull. Is the best way I could phrase it. For subdural hematoma, it is like it's like a crescent shape typically. This one picture that I have right offhand, which I'm not showing you, but I have it on hand, is not a great example, but that is subdural hematoma. It's like a crescent shape, kind of just going across the entire side. Now, the interventricular is typically more blurry or something like that. I'm mistaken. Sorry, subarachnoid is kind of blurry. So, I'll go back into what we were talking about before. No, where were we? Okay. Worst headache of my life. I have the worst headache of my life. What are we thinking right now? You should think about subarachnoid hemorrhage. That sucks, and obviously it can kill you, but the headache is also bad too. For reference, subarachnoid hemorrhage. Resting tremor, rigidity, akinesia, shuffling gait, micrographia, postural instability. What are we thinking about that? What are we thinking? Parkinson's disease. Parkinson's disease causes that rigidity, akinesia. It has a resting tremor, right? And it also has postural instability. And you also have shuffling gait, Parkinson's gait, right? Shuffling. And micrographia, it's kind of weird. A little writing, Parkinson's disease, loss of dopaminergic neurons in the substantia nigra pars compacta. And you also have elevated acetylcholine as well, which is the secondary issue. Chorea, dementia, caudate degeneration. What are we thinking? Huntington disease, loss of the GABAergic neurons in the striatum, autosomal dominant CAG, repeat expansion. Fair enough. Huntington's disease, you have that kind of limitation. Let me check something quickly. Okay. Well, that should be fine. I'll be fine. I think I should be okay. Not much I can really do about that. Anyway, I want to wrap this up soon. Where are we? Urinary incontinence, gait apraxia, and cognitive dysfunction. What are we thinking with that one? A normal pressure hydrocephalus, ventricle expansion, distortion of corona radiata fibers. So that goes back into the wet, wacky, wobbly, right? You have urinary incontinence, you have ataxia, and you have cognitive dysfunction. Relapsing and remitting nystagmus, intentional tremor, optic neuritis, scanning speech, bilateral internuclear ophthalmoplegia. What are we thinking? When you hear relapsing, remitting, immediately think MS. MS is a big one. That's multiple sclerosis. Progressive, ascending, symmetric limb weakness and hyperreflexia after GI upper respiratory infection. Progressive, ascending, symmetric limb weakness and hyporeflexia. After you had a GI or you had a upper respiratory infection, think about Guillain-Barré syndrome, which is an acute inflammatory demyelinating polyneuropathy. Again, that's it's a peripheral nerve issue. So MS is central, CNS, right? But Guillain-Barré is peripheral. Messes with the, I like to say Schwann cells, if I'm not mistaken. Let me look that up right now. What cells does Guillain-Barré affect? I think it's Schwann cells. Yeah, it is Schwann cells. So let me go back to that. So basically, Guillain-Barré is like a peripheral equivalent of MS. It was induced by something like Campylobacter jejuni, for example, or some other kinds of conditions, or other kinds of diseases which can induce it initially. But it's an acute inflammatory demyelinating polyneuropathy. Café au lait spots. Have we heard that a lot about those today? Lish nodules, iris hamartomas, cutaneous neurofibromas, pheochromocytomas, optic gliomas. What are we thinking? Neurofibromatosis type 1. So again, you still have pheochromocytoma, you still have a café au lait spot. We've heard a lot about that, but we've heard about both of those today so far. But Lish nodules as well, and also optic gliomas. What else do we have? Bilateral vestibular schwannomas. What are we thinking? Neurofibromatosis type 2, so NF2. If you had the schwannomas causing the issues with the ears, right, with hearing, I think, that is a type NF2. If you don't have that part with it, that's probably NF1 then. Schwannomas are the schwannomas of the sides inside the head. Those are going to be characteristic of the NF2 specifically. Vascular birthmark, port wine stain on face. What are we thinking? Okay, here we go. I said, for example, what was it again? Vascular birthmark, port wine stain on the face. It's Navis flammeus, benign, associated with the Sturge-Weber syndrome we were talking about before. So, but that's port wine stain, Navis flammeus. That's the Sturge-Weber syndrome. Bilateral renal cell carcinoma, hemangioblastoma, angiomatosis, and pheochromocytomas. What are we thinking? Von Hippel-Lindau syndrome, VHL deletion on chromosome 3p. Okay, hyperreflexia, hypertonia. Babinski is positive. What are we thinking with that? Upper motor neuron lesion, upper motor neuron damage, right? Well, let's say the opposite. Hyporeflexia, hypotonia, atrophy, fasciculations, which is like twitching. What are we thinking with that? Lower motor neuron damage. So when it's hyporeflexive and hypotonic, and they both have weakness, by the way, but if it's hyporeflexive, hypotonic, you're thinking lower motor neuron. If it's hyperreflexive and hypertonic, it's going to be upper motor neuron. Staggering gait, frequent falls, nystagmus, hammer toes, diabetes mellitus, hypertrophic cardiomyopathy. What are we thinking? Friedreich ataxia. A lot of stuff going on with that one. But staggering gait is Friedreich ataxia with that. Unilateral facial drooping involving the forehead. What are we thinking with that one? Lower motor neuron, facial nerve, cranial nerve 7 palsy, Upper motor neuron lesion spare the forehead due to bilateral innervation. So just bear that in mind. When it's upper motor neuron, the forehead is okay, and it's also going to be contralateral. They don't even mention that, do they? No, they don't mention that. Let's say, for example, I have a right-sided issue, right-sided nerve problem, and it's going to be upper motor neuron. That'll cause a left-sided lower part of the face problem. Okay? So right upper motor neuron leads to a left lower face issue. Let's say it's a right lower motor neuron issue. Then what that causes a right whole side of my face issue. So it's the same side of the face when it's lower motor neuron rather than contralateral. And it's going to be both the forehead and the lower part of my face. So just keep that in mind. It's kind of confusing when you first read about it. I know it's very confusing for me for a long time, but that's my understanding of the situation. And it's because of the bilateral innervation for the lower part of the face, or for the upper part of the face. On to the next page. I'm going to take a brief break, but not that long. We only have a little bit left until we get to the next section, which I'll close the stream at that point. Okay, cool. So, next stuff. Last little block of this particular section to wrap up the stream. Episodic vertigo, tinnitus, sensorineural hearing loss. What are we thinking with that one? Meniere's disease, increase in endolymph in inner ear. Ptosis, and that's a good way to remember that too, because we talk about vertigo a lot. There's different kinds of vertigo or different kinds of presentations. If you have episodic vertigo, you should start thinking about Meniere's disease. Ptosis, meiosis, anhidrosis. What do we think with that one? Horner syndrome, right? Yeah, sympathetic chain lesion problem, right? Conjugate horizontal gaze palsy, horizontal diplopia. What do we think with that? What do you think about that? Internuclear ophthalmoplegia. That's an MLF lesion, unilateral or bilateral. So let's say, for example, my left eye cannot look medially. Cannot look medially. What does that mean? I have a left INO. I have a left MLF lesion. My left eye cannot look to the right. That means I have a left. If I have issues looking to the right because my left eye cannot look medially to that right side, I have a left MLF lesion, giving me I have a left INO. Make sense? I think MLF is medial longitudinal fasciculus, if I'm not mistaken. Okay. Acute onset, reversible waxing and waning level of consciousness, acute onset, decrease in attention span, decrease in arousal. Well, that's delirium. Usually secondary to other causes. Very, very true. For many different causes. Polyuria, renal tubular acidosis type 2, growth retardation, electrolyte imbalances, and hypophosphatemic rickets. Well, they don't even describe the main problem. Let me go into it. It's something that I need to read more into. I'll phrase it like that. It's Fanconi syndrome. Generalized reabsorption defect of proximal convoluted tubule. So Fanconi syndrome is going to lead to that RTA, renal tubular acidosis type 2, right? That's the type that's going to be associated with the PCT. And, yeah. I'll hear about this. Periorbital and or peripheral edema, proteinuria greater than 3.5 grams a day. This should send an alarm bell in your head. Frothy urine, hyperalbuminemia, hypercholesterolemia. What are we thinking with that? Nephrotic syndrome. Podocyte damage, right? And again, when it says greater than 3.5 grams of protein, that is going to be nephrosis. If it's less than that, it's nephritis. Nephrotic is more than 3.5. Nephritic is less than 3.5 for protein loss per day of grams. Hereditary nephritis, sensorineural hearing loss, retinopathy, anterior lentoconus. What are we thinking? Alport syndrome, which is a type 4 collagen mutation. Wilms tumor, macroglossia, like a big tongue, organomegaly, hemihyperplasia, and omphalocele. What do we think with that? Beckwith-Whiteman syndrome, WT2 mutation. Okay. Streak ovaries, congenital heart disease, horseshoe kidney, cystic hygroma, short stature, webbed neck, lymphedema. That doesn't sound great. That sounds like a pretty serious condition. That's Turner syndrome. It is pretty serious. You're missing, it's someone who's female who is missing an entire X chromosome. So they're female, they have, female sex organs, right? But they're infertile. They can't really have kids. They're kind of in a weird spot, essentially. And they're short. Conversely, people who have an extra X chromosome are taller, typically, right? So if you have an X chromosome that's missing, you will be shorter. She's shorter. Turner syndrome will be shorter. And you have a webbed neck and all the other kind of stuff, right? I think typically, though, if you have Turner syndrome, your IQ, your intellectual capacity is typically normal. The opposite is true for if you have an extra chromosome, let's say an extra X chromosome, you have 3 X chromosomes, you have an XXY chromosome, you have an XYY. They typically they're usually taller and they're usually less intelligent. If you have a missing X chromosome, you're usually shorter, but your IQ is pretty normal. Again, the deficiency in IQ because of more chromosomes, more sex chromosomes is usually not big, but it is notable. Something you can record and notice the difference when you compare averages. So, anyway, ovarian fibroma, ascites, pleural effusion. What is that going to be? Meigs syndrome. I'm saying Meigs. I don't know if it's Meigs or Meigs. It's MEIGS. Meigs syndrome. Ovarian fibroma, ascites, pleural effusion. Red, itchy, swollen rash of nipple or areola. Paget's disease of the breast, sign of underlying neoplasm. Okay. Fibrous plaques and tunica albuginea of penis with abnormal curvature. Let's see. What do we think? It's going to be Peyronie's disease. Peyronie, so Peyronie disease, associated with repeated minor trauma during intercourse. Okay. Hypoxemia, polycythemia, and hypercapnia. If you have a lot of carbon dioxide, you have a lot of red blood cells, presumably polycythemia. Hypoxemia, what's going on with that? Chronic bronchitis, hypertrophy and hyperplasia of mucus-secreting glands. Interesting. So chronic bronchitis will cause polycythemia, hypercapnia, and hypoxia. Hypoxemia is like thinking well, how could that be? How could it be that you have a lot of red blood cells, and you don't have a lot of oxygen? What's going on? It's because the lungs are the problem. And when you have hypoxemia, because you have chronic bronchitis, because your lungs are messed up, your body's going to say, oh, we need to increase our red blood cells to compensate. And as a consequence, you just have a lot of red blood cells which just don't have a lot of oxygen. Because the real root problem is not the RBCs, it's the lungs. But whatever. Pink complexion, shortness of breath, hyperventilation. What are we thinking? Emphysema, centroacinar of tobacco smoking, or panacinar with an alpha-1 antitrypsin deficiency. That's important to know. If it's an alpha-1 antitrypsin deficiency, it is panacinar, okay? Panacinar. If it is a tobacco-related issue for emphysema, it's going to be centroacinar, okay? Tobacco, centroacinar, alpha-1 antitrypsin deficiency, panacinar. Bilateral hilar adenopathy, uveitis, arthropathy, skin changes. What are we thinking? It's bilateral hilar adenopathy, uveitis, okay, arthropathy, skin changes. We're thinking sarcoidosis. Sarcoidosis, immune-mediated non-caseated granulomas. Okay. Well, that concludes that section of the rapid review. We would theoretically go on to the part that's called classic labs/findings. I am not going to do that today. This has been a 4 hour and 21 minute and counting stream. 24 hours, 21 minutes, and 15, 16, so 4 seconds, whatever. Very long, longer than I expected. I thought this was going to take 3 hours because it's 30 pages. But unfortunately, because of the fact that this material was a lot more dense compared to our other material, it's actually going to be a lot longer than that. So, I'll have to review this a little bit on my own as well. You can obviously review the textbook, either the PDF that might be available online, or by just buying the textbook. Anyways, it's been an interesting stream, perhaps, and thank you for listening.